गुड इवनिंग एवरीवन। गुड इवनिंग, शुभ संध्या। कैसे हो आप सब? हाउ आर यू ऑल? कैसी कट रही जिंदगी? फर्स्ट ऑफ ऑल, विशिंग अ वेरी हैप्पी डॉक्टर्स डे टू ऑल बडिंग डॉक्टर्स, ऑल डॉक्टर्स। डॉक्टर्स डे का मतलब है वी हैव टू टेक ए प्लेज, वी हैव टू टेक ए ओथ that we will be fair to mankind, we will serve mankind. हम दुनिया के लिए ईमानदार रहेंगे, we will remain faithful or honest for everyone, so we expect everyone to be faithful to us as well. डॉक्टर्स कभी कभी सॉफ्ट टारगेट हो जाते हैं, तो डॉक्टर्स डे पे एक छोटा सा मैसेज है टू ऑल द बडिंग डॉक्टर्स कि जिंदगी में इतना सॉफ्ट टारगेट नहीं बनना। जो सॉफ्ट है उसके साथ सॉफ्ट है, जो सॉफ्ट नहीं है उसके साथ डॉक्टर भी सॉफ्ट नहीं है। डॉक्टर 5 साल 5.5 साल एक एमबीबीएस की पढ़ाई करता है और एमबीबीएस की पढ़ाई में वो इतना मैच्योर हो जाता है, ही कैन टैकल एवरीथिंग इन लाइफ। हम जिंदगी में किसी भी चीज को फेस कर सकते हैं। डॉक्टर्स आर द क्रीम ऑफ सोसाइटी, वी ऑल आर गोइंग टू बी द क्रीम ऑफ सोसाइटी। लोग हमें फंक्शंस में बुलाना पसंद करेंगे। हम वो बनने जा रहे हैं जिसके बारे में हमने कभी सोचा भी नहीं था। इन 5.5 सालों में पढ़ते पढ़ते और फिर एफएमजी एग्जाम की तैयारी करते करते क्या से क्या हो गए हम, ये हमें खुद समझ नहीं आया। सो वंस ऑल विशिंग यू अ वेरी हैप्पी डॉक्टर्स डे। तो आज का सेशन स्टार्ट करते हैं। वील ट्राई टू कवर 25 इंपॉर्टेंट क्लिनिकल विग्नेट बेस्ड क्वेश्चंस which are really very important for our upcoming 30th July FMGE exam. एक महीना बचा है, एक महीना भी पूरा कहां बचा है यार, 1 तारीख की शाम हो गई। लेकिन इन 29 days में we can change the game. And in today's session, I will try my level best to contribute those 30 marks for you, 30 out of 300. NBE बोलता है कि OBG 30 नंबर का आएगा 300 नंबर के क्वेश्चन पेपर में, लेकिन इतिहास गवाह है कि हमेशा 30 नंबर से ज्यादा का आता रहा है। और आज के इस सेशन में, इन दिस सेशन, आई विल ट्राई माई लेवल बेस्ट टू कंट्रीब्यूट समथिंग इन योर लाइफ, टू एड सम वैल्यू इन योर लाइफ। सो लिसन टू ऑल द क्वेश्चंस वेरी केयरफुली, लिसन टू ऑल द ऑप्शंस वेरी केयरफुली, एंड लिसन एंड लर्न हाउ वी विल बी एक्सक्लूडिंग 3 options and we will choose the most appropriate answer after clinically dissecting everything. So we are starting with our session of 25 important obs-gynae questions. Let's move to question number 1. आज के इस सेशन से 30 जुलाई को हमें बहुत फायदा होने वाला है। We are going to be benefited like anything on 30th July FMG exam because I have tried my level best to prepare this 25 questions clinical vignette based question in such a way कि यार ऑलमोस्ट सारा कवर हो जाए, जो इंपॉर्टेंट एरिया है ऑब्स्टेट्रिक्स का भी और गायनी का भी। और अपने आप में चारों ऑप्शंस मैंने ऐसे रखे हैं जिससे कि एक क्वेश्चन में हमको 4 क्वेश्चन मिलेंगे। सो दीज 25 क्वेश्चंस आर गोइंग टू गिव यू 100 क्वेश्चन, एंड बिलीव मी, OBG is going to be the game changer on 30th of July FMG exam. Believe me, mind my words. Let's move to question number 1. A primigravida lady presents with history of amenorrhea for 3 years. Okay, 3 महीने से उसको पीरियड आया ही नहीं। She was on oral contraceptive pills and got pregnant. So she is unaware about last menstrual period. Ultrasonography shows a gestational sac with yolk sac and embryo. Cardiac activity is not visualized. To call this pregnancy missed abortion, the minimum crown rump length measured on ultrasonogram should be. एक क्वेश्चन थोड़ा बड़ा हो गया ना यार। दिस इज द 6 लाइनर क्वेश्चन, थोड़ा सा बड़ा बना दिया क्वेश्चन मैंने। बट हाउ टू गेट द क्रक्स ऑफ द क्वेश्चन, वी शुड रीड द लास्ट लाइन ऑफ द क्वेश्चन। द मिनिमम क्राउन रम्प लेंथ मेजर्ड ऑन अल्ट्रासोनोग्राम शुड बी। So if examiner is talking about ground rump length of the embryo means CRL of the embryo, and CRL is the best ultrasound parameter for assessment of gestational age overall and in first trimester. And we know missed abortion is said if ground rump length is 7 millimeter or more than 7 millimeter. So answer to this question is very simple, 7 mm. But let's have a look at the option number 1, 8 mm. What does it mean? What is 8? How do you correlate the figure 8 in the topic abortion? Can anyone answer me? How do you correlate? This is a chocolate question, and those who are answering the question correctly will get the chocolate for this question. How this 8 number is related in the topic abortion? Listen to my question very carefully. How this number 8 is related to topic abortion? Can anyone? I am waiting for your answer. Answer to this question is 7 mm, beta, I know very well. But my question to you is, how number 8 is related to the topic abortion? मैं थोड़ा दूसरे टाइप का क्वेश्चन पूछ रहा हूं आज. How this number 8, can anyone? Super duper, big chocolate question now. This is a big chocolate question. How number 8 is related to the topic abortion? How number 8 is related? No, beta, Hagar dilator number 8, Hagar dilator number 8, that is to diagnose cervical incompetence in non-pregnant lady. Prashant, you are right. You are right. Hagar dilator number 8, Prashant, you are right. How else it is related? A. Maximum time of abortion is before 8 weeks. Let's crack the single liner question as well. What is the most common time of abortion? Maximum abortions occur before 8 weeks. So single liner is done. How number 12 is related to topic abortion? Again a chocolate question. How this number 12 is related to the topic abortion? Can anyone? Big chocolate question. How number 12 is related to the topic abortion? I told you, I have tried to put all the options in such a way so that we can almost cover the whole obstetrics and gynecology today in this 25 question session. How number 12 is related to the topic abortion? Early pregnancy loss. What is early pregnancy loss? If pregnancy loss occurs before 12 weeks, that is called early pregnancy loss. So that's single liner number 2. First single liner was most common time of abortion is before 8 weeks. Done. Single line number 2, early pregnancy loss is said if pregnancy loss occurs before 12 weeks, and new name for abortion is pregnancy loss. My third question to you, how the number 25 is related to the topic abortion? Can anyone? How number 25 is related to the topic abortion? How number 25 is related to topic abortion? Quickly, quickly, let's move ahead, fast. How number 25 is related to topic abortion? 25 number is related to, 25 number is related. Wow! Anupriya! This chocolate is for you, Anupriya. This chocolate is for you, Anupriya. Can we have a big round of applause for Anupriya? Wonderful. 25 number is related to blighted ovum. Wonderful, wonderful Anupriya. This chocolate is for you. You can collect this chocolate from me anytime. Wonderful. And let's go through the images. Let's go through the images quickly. This is how a normal live pregnancy looks like on ultrasound. You can see this ultrasound beam is passing through the fetal heart, and if fetus is alive, you can see these cardiac pulsations. These are cardiac pulsations indicating that this fetus is alive. This is a live pregnancy. Our question was related to missed abortion. You can see this is the gestational sac here. In this gestational sac, this is the yolk sac here, and this is the embryo. And this is the ultrasound beam which is passing through embryo. And this is not a live fetus, this is a dead fetus, as you can see a flat line. There are no cardiac pulsations, as you can see here. This was a live fetus. If fetus is alive, we will see fetal cardiac tracing like this. There will be pulsation. But if it is a missed abortion, when ultrasound beam is passing through fetal heart, we are seeing a flat line, and when we use the word missed abortion, if the length of this embryo, that is crown rump length, is 7 millimeter or more than 7 millimeter and cardiac activity is absent. This is blighted ovum, as Anupriya answered correctly, and Anupriya deserves this chocolate. This is a blighted ovum. What is a blighted ovum? It is also called an embryonic pregnancy when there is an empty gestational sac without any embryo. And when we use the word blighted ovum, if size of the gestational sac is 25 millimeter or more than 25 millimeter and it is still empty. So if we are given this image question, we will answer it correctly. Few other image questions, important ones related to this topic. Identify this syringe. This is menstrual regulation syringe used for MTP up to 7 weeks of pregnancy. So this is used for MTP up to 7 weeks of pregnancy. How do you identify that this is the menstrual regulation syringe? There is only one pinch valve here. There is another syringe which is manual vacuum aspiration syringe. And how do you identify that this is the manual vacuum aspiration syringe? There are two pinch valves here, one here, one here. So if there are two pinch valves, this is a manual vacuum aspiration syringe, and with manual vacuum aspiration syringe, we can do MTP up to 12 weeks, while with menstrual regulation syringe, we can do MTP up to 7 weeks. And we all know that this menstrual regulation syringe is a 50 cc syringe, while this manual vacuum aspiration syringe is a 60 cc syringe. Fine. This is how CRL is measured. This is CRL, crown rump length. This CRL is answer to the question, best ultrasound parameter for assessment of gestational age in first trimester is CRL or crown rump length. Crown means top of head to bottom of buttock. This is how we measure the length of embryo. And if it is 7 mm or more than 7 mm and there are no heart pulsations, this is called missed abortion. This is biparietal diameter. This is one parietal eminence. This is another parietal eminence. And if we measure the distance between two parietal eminence, this is called biparietal diameter, and this is the best ultrasound parameter for assessment of gestational age in second trimester. This is the femur length, femur bone, thigh bone beta. This femur length is best ultrasound parameter for assessment of gestational age in third trimester. These are very, very important questions for our exam. So in this question, the question asked was, when we use the word missed abortion, if crown rump length is 7 millimeter or more than 7 millimeter. This is again an important image question for our exam. This is Carmen's cannula, and this Carmen's cannula is used for suction evacuation. Suction evacuation is the best method of MTP in first trimester. Another single liner question, what is the most common method of MTP in first trimester? That is medical abortion. Best method of MTP in first trimester is suction evacuation. Other important MCQ areas beta, how much is the suction pressure in suction evacuation? It is 660, around 600 millimeter of mercury. Suction pressure in suction evacuation is 600 millimeter of mercury. Another very important question related to Carmen's cannula is diameter of cannula in millimeter correspond to gestational age in weeks, which again correspond to number of cannula. Suppose we are doing MTP for 8 weeks pregnancy. Which number cannula will be used? 8 number. And how much is the diameter of 8 number cannula? 8 millimeter. 10 हफ्ते की प्रेगनेंसी है, 10 नंबर का कैनुला यूज करेंगे और 10 नंबर के कैनुला का डायमीटर कितना है? 10 मिलीमीटर. ये हमारे बड़े बड़े इंपॉर्टेंट एमसीक्यूज से रिलेटेड टू अबॉर्शन. क्वेश्चन नंबर 2. दूसरा क्वेश्चन सॉल्व करते हैं. a lady with recurrent early pregnancy losses. A lady with recurrent early pregnancy losses presents for evaluation. Hysterosalpingography shows given image. The most likely diagnosis is. So this is the hysterosalpingography image. The lady is presenting with recurrent pregnancy losses. And we know congenital malformations of uterus commonly cause recurrent abortion. How will you identify what is this? First of all, we should be able to identify what is this investigation. If we see a X-ray film, and in X-ray film we see this white color of dye, it means it is a hysterosalpingography because there is a Leach-Wilkinson cannula here, and this is the uterus here. Why we do not see a dye in the midline? Because this is a midline filling defect, and this midline filling defect is due to septate uterus. So what is this abnormality? This abnormality is a septate uterus. Septate uterus में बेटा बीच में पतला और लंबा एक फिलिंग डिफेक्ट दिखता है. Why we see this filling defect here? क्योंकि यहाँ पे सेप्टम है बेटा, और क्योंकि यहाँ पे सेप्टम होता है तो यहाँ पर डाई नहीं जाती. We see a filling defect here because of presence of septum here. We can easily identify that this is a case of septate uterus. Another important MCQ here, कोई बताएगा? Again a chocolate question. बोलो जल्दी से. Which dye is used for hysterosalpingography? HSG के लिए हम कौन सा डाई यूज करते हैं? हिस्टेरोसल्पिंगोग्राफी. मुझे बताना, तब तक मैं दूसरा दिखाता हूं. Wonderful, wonderful. You all are answering like anything. Ma. Wonderful, wonderful. Very nice, very nice. Which dye is used for hysterosalpingography? तब तक हम इमेज देखते हैं. मैं वेट कर रहा हूं आपके आंसर का. अगेन दिस इज ए चॉकलेट क्वेश्चन. व्हाट इज दिस? बताओ. व्हाट इज दिस एबनॉर्मलिटी? बोलो जल्दी. व्हाट इज दिस एबनॉर्मलिटी? बताओगे? देखो जल्दी जल्दी बताना है ना हमको. विल स्पीक आउट. बहुत सारी चॉकलेट है. चॉकलेट का कोई चिंता नहीं. चॉकलेट का ट्रक खड़ा हुआ है. 5-7 ट्रक एक साथ ऑर्डर कर देंगे. खूब सारी चॉकलेट खाएंगे, चॉकलेट पार्टी करेंगे. बस आंसर करते जाओ. सबको पास होना है. पास होना है. All FMGs should be able to clear the exam. दिल से तमन्ना है. दिल से तमन्ना है. सारे FMG पास हो जाए. What is this? This is bicornuate. Wonderful. This is bicornuate. Oh my God! सारी चॉकलेट का आधा ट्रक खाली हो गया भाई. आधा ट्रक खाली हो गया चॉकलेट का. और वाह, bicornuate. और उस क्वेश्चन का आंसर बोलो. Which dye is used for hysterosalpingography? Which dye is used for HSG? Which dye is used for hysterosalpingography? बोलो 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 बोलो. बड़ा इंपॉर्टेंट क्वेश्चन है यार. जब हमसे इतना सिंपल क्वेश्चन पूछ सकते हैं 3 साल पहले. Which dye is used for laparoscopy? Our exam question and answer was methylene blue. The question in waiting is which dye is used for hysterosalpingography? Radio opaque dye, what is the name? Yes, urographene. Wonderful. Urographene. Rupali, you are correct. Abdul, you are correct. Navrang, you are correct. Om Verma, you are correct. Muhammad Adil, you are correct. Jay Gosia, you are correct. Wow. Shade, you are correct. Shubhangi, you are correct. Wonderful. Kishore, Motilal, Aditya. Yes, the correct answer is urographene. So which dye is used for hysterosalpingography? Urographene. अब यार जल्दी से काम करते हैं. How will you differentiate? This is bicornuate and this is septate. जरा जल्दी से काम कर लें. Septate में देखो एक clue, एक छोटा सा clue बताता हूँ. Septate में these two horns, they are close to each other because it is a normal uterus with only a septum in the midline. So we only see a midline filling defect. तो septate uterus में uterus के दोनों horn पास होते हैं. अब जरा bicornuate देखते हैं. Bicornuate में दोनों ना दूर कितना दूर हो गए देखो, है ना. They are far apart and theoretically also we know this distance has to be 4 centimeter or more than 4 centimeter, while in septate uterus this distance is less than 4 सेंटीमीटर हमको पता है. So we can easily differentiate. This is a septate and that is a bicarbonate. और भी तो देख लो यार. This is a normal hysterosalpingography. Normal HSG देखो. This is a normal hysterosalpingography. Which device is used for hysterosalpingography? Leach-Wilkinson cannula. This is the Leach-Wilkinson cannula. As you can see, we instill this urographin dye via Leach-Wilkinson cannula. This dye is filling uterus, so you can see the whole uterus is wide. Whole uterus is wide, beta. यहाँ बीच में पतला, लंबा, filling defect नहीं दिख रहा. जल्दी से दोबारा से septate दिखा देता हूँ. Now you can compare a septate uterus with a normal hysterosalpingography. ये abnormal है क्योंकि यहाँ पूरा white नहीं दिख रहा. ये normal HSG है. We can see the whole uterus filled with the radio-opaque dye, making it white. And we can see the dye is traveling on either side, traveling via fallopian tube and coming out of fallopian tube, which is called spill of dye. So this is normal HSG. If dye is coming out of fallopian tube, tubes are patent. Which abnormality is this? Again a chocolate question. Come on, everyone. Very, very important questions for our exam. Very, very important questions for our exam. Which abnormality is this? Come on. Which abnormality? This is uterine diidal phase. This is uterine diidal phase. How do you identify that this is uterine diidal phase? There are two Leach-Wilkinson cannula because this is the only abnormality in which there are two vagina. Since there are two vagina, we have to use two Leach-Wilkinson cannula to instill the urographin radio-opaque dye. So if we see two vagina, two Leach-Wilkinson cannula, two separate uteri, this is the case of uterine diidal phase or double uterus. Tell me, which congenital malformation of uterus is this? ये कौन सी abnormality है बताओ? जल्दी से बोलो. What is this? Everything is present only on one side and nothing is present on opposite side. So this is the case of unicornuate uterus. कौन सा है ये? This is a unicornuate uterus, which is also called penis-shaped or banana-shaped uterus. Chalo. What is the gold standard method? This question was asked in NEET PG on 5th March 23 this year. Which is the best method to diagnose uterine cavity pathologies? The answer is hysteroscopy. This is camera of uterus. This is hysteroscope. Answer to the MCQ. Best method to diagnose pathologies of uterine cavity is hysteroscopy. And this is the hysteroscopy image. Again a chocolate question. Who will answer this question? Again a chocolate question. Who will answer this question? This is the hysteroscopy image. This is the hysteroscopy image of which congenital malformation of uterus? Anyone? This is a hysteroscopy image of which congenital malformation of uterus? Wonderful. Septate. Wonderful. Abdul. Wonderful. Umesh. Navrang. Anupriya. Aditya. Prateek. Wow. Avinash. Ekta. I'm so happy to see Samota. I'm so happy to see that all of you are actively participating. It indicates your energy and it indicates how much you have studied and how you are revising. That's which matters. This is the hysteroscopy image of septate uterus. As you can see here, this is the septum in the midline. This is the septum in the midline. So this is the hysteroscopy image of septate uterus. Now I am asking you another question. This is the laparoscopy image of which congenital malformation of uterus? This is the laparoscopy image of which malformation? Tell me. This is the laparoscopy image of which congenital malformation? This is lap. You are asking, how will I give you the chocolates? If we meet, I will give you the chocolates. If we meet, I will give you the chocolates, or you can note down my phone number 7042109992. I love giving chocolates. You can WhatsApp me, write your name, and then we will decide when we will meet and I will give you the chocolates. Fine? So this is my phone number. This is how you can communicate with me and collect your chocolates. I am coming back to my question. This is the laparoscopy image of which congenital malformation of uterus? Bicornuate, wonderful. Sanjoli, Pranadhya, Ashok, Jitendra, Uma, Kishore. I remember all the names and I will give chocolates to you all. Pranav, Kumar, Jay Gopi, Sabatina, Priyanka. Wonderful. So this is a bicornuate uterus. Fine. Let's move to question number 3. A lady presents at 30 weeks gestation with sudden abdominal pain. A lady presents at 30 weeks gestation with sudden abdominal pain. She is found to be hypertensive and blood pressure is 170-120 millimeter of mercury. Per abdominal examination was done which revealed fundal height corresponding to 32 weeks gestation. Okay, ji. Abdomen and uterus are hard and tender. Fine. Fetal parts are not palpable. Okay, ji. Fetal heart sound are not audible. That's okay. Which of the following is most likely? So look at this question. Again, this is a 6-liner question. And the crux of the question is, she is presenting at 30 weeks of pregnancy. So her gestational age is 30 weeks. Now, let's have a look. What is the problem? She is complaining of sudden abdominal pain. It is not a gradual pain. It is started suddenly. Okay. We examined her and we found that she is hypertensive. Her BP is high. So examiner is taking us to a 30 weeks pregnancy who is presenting with sudden abdominal pain. Her blood pressure is high, 170/120. We understood this much by now. And we examined her abdominally, and on per abdominal examination, the pregnancy duration appeared to 32 weeks. She is saying, Dr. Saab, I am 30 weeks pregnant, but on fundal height examination, we see that this is a 32 weeks pregnancy. 32 weeks pregnancy means fundal height is at the junction of 2/3 from umbilicus and 1/3 from xipisternum. It is here. So fundal height is more than period of amenorrhea. How come is it possible? Fine. Other problem is, once we palpated her abdomen and uterus, we found that abdomen is hard and uterus is also hard and tender. We tried to palpate the fetal parts, but they are not palpable. We tried to auscultate the fetal heart sound, they are not audible. What is happening? If you correlate the option, uterine rupture, why it is not a case of uterine rupture? Why it is not a case of uterine rupture? In cases of uterine rupture, beta, what will happen if uterus ruptures? Just have a look at me. If uterus ruptures, beta, fetus will come out. If uterus ruptures, fetus will come out of uterus, and if we try to palpate the fetal parts, we will be able to palpate them very easily. क्योंकि यूट्रस फट गया बेटा, अगर यूट्रस फट गया तो बच्चा ऊपर आ गया. अगर बच्चा ऊपर आ गया, मैं अपना हाथ एब्डोमेन पे रखूंगा तो बच्चा मुझे इजीली पाल्पेट हो जाएगा. यूट्राइन रप्चर इज गॉन. मोर ओवर, इफ इट वॉज द केस ऑफ यूट्राइन रप्चर, यूट्रस फट जाता बेटा, बहुत मैसिव ब्लीडिंग होता, बहुत मैसिव ब्लीडिंग होता तो उसका बीपी फॉल करता. यहां उसका बीपी बढ़ा हुआ है. Abruptio placentae. This is the case of abruptio placentae because hypertension is a risk factor for abruption. And if she presents with abruption, she presents with abdominal pain. What is the reason for pain in abruption? Reason for pain in abruption is thromboplastin. Thromboplastin is a uterotonic which is released after placental abruption, which increases uterine tone. Due to increased uterine tone, her symptom is abdominal pain, and due to increased uterine tone only, when we try to find the signs, abdomen and uterus appear hard and tender. And the reason for hardness and tenderness is thromboplastin, which is a uterotonic which is released after placental abruption. Since abdomen and uterus are hard and tender, fetal parts are not palpable. This is the only reason we find difficulty in auscultating fetal heart sound. So answer to this question should be abruptio placentae. But we are in habit of reading all the options till last word. Uterine dehiscence. Why it is not a case of uterine dehiscence? What is the difference between uterine rupture and dehiscence? Uterine rupture means all the layers of uterus are separated, including the outermost layer, uterine serosa. While uterine dehiscence says all the layers of uterus are separated, but outermost layer of uterus, that is serosa, is intact. If it was a case of uterine dehiscence, again, what could happen? She could not be hypertensive. She could not be hypertensive like this. Why she will be presenting with sudden abdominal pain? In uterine dehiscence, there will be pain only in the scar area, and sign will be scar tenderness only. Fine. Fetal heart sound will definitely be audible with uterine dehiscence. In uterine dehiscence, there is fetal tachycardia. In uterine dehiscence, fetal tachycardia. In uterine rupture, fetal bradycardia, and finally fetus die. Dehiscence मतलब यूट्रस फटने वाला है, तो बच्चा लड़ रहा है अंदर, तो फीटल टैकीकार्डिया. जब यूट्रस फट गया, बच्चा हैंड्स अप, फीटल हार्ट रेट गिरता है और बाद में बच्चा खत्म हो जाता है. Intrauterine fetal demise. If it was a case of intrauterine fetal demise, why her BP could be very high, why abdomen and uterus was hard and tender, and why fundal height is more than period of amenorrhea, because this is a variety of concealed abruption. In concealed abruption, retroplacental clot is there because that blood is not coming out, and that retroplacental clot is contributing to increased fundal height. Let's go through few images here. If this image is given in our exam, identify the condition. This is the case of placental abruption. Look here, this is the placenta here, this one is placenta, and this placenta is detached from uterus. Because placenta is detached from uterus, you can see this retroplacental clot, this blood clot behind the placenta. So if this kind of image is given, and we are given this image question, identify the condition, and if placenta is not properly attached to uterine wall, this is the case of placental abruption. This is the case of covaliar uterus. Covaliar uterus is seen in concealed placental abruption, where retroplacental blood reaches up to outermost layer of uterus serosa, so uterus becomes pinkish white, bluish white, wine colored, which is called covaliar uterus or uteroplacental apoplexy. This is the ultrasound image of placental abruption. You can see that this is the placenta and this was the uterine wall. This is uterine wall, and now this placenta has been detached from uterine wall, and all this is retroplacental blood between placenta and uterine wall. Now I am erasing everything, and you can easily recollect this ultrasound image. If this placenta is detached from uterine wall, this is abruptio placentae. This is a case of concealed abruption in which retroplacental blood collects inside, while in revealed abruption, abruption occurs in such a way that this retroplacental blood comes out of vagina. This is a very important image question for our exam, has been asked multiple times in various exams. Identify the condition, and this is the case of placenta previa. As you can see, this placenta is occupying the lower part of uterus. This is covering internal os. So the difference in two conditions is very, very important image questions for our exam. This is the case of placenta previa, where placenta is present in lower part of uterus, touching or covering internal os, while this was the abruptio placentae. Placenta was in lower part, but it was detached from uterine wall. This is the ultrasound image of normal placenta. This is the placenta, lower edge of placenta which is finishing here, and this is the level of internal os. If you try to measure this distance between lower edge of placenta and internal os, this distance should be at least 2 centimeter. And if this distance is at least 2 centimeter, this is a normally located placenta. And what is the most common location of placenta? Most common location of placenta is fundoposterior because most common site of interstitial implantation is fundoposterior. Beta, whatever I am trying to speak out in this session are very, very important clinical questions, and along with that, I am trying to cover very, very important single liner questions also. So what is a normally located placenta? If lower edge of placenta is at least 2 centimeter away from internal awl. This is a case of placenta previa, posterior one. If you compare it, look here. This is the placenta which is finishing here, and this is the level of internal awl. So this is a posterior placenta previa. This is the anterior placenta previa. This placenta is on anterior wall of uterus, and this is the level of internal awl. There is a RRS method for study. Many students are sending messages. सर याद नहीं होता, कोशिश बहुत करते हैं, वी आर ट्राइंग टू रिवाइज, लेकिन ऐसा लगता है कि अब थोड़े दिन कम बचे हैं, 1 महीना बचा है, याद नहीं हो रहा. If you find any difficulty in memorizing the stuff, try to follow this RRS method. What is this RRS method? Read, repeat, speak out. Just read, repeat and speak out all those areas which look volatile to you. यार याद नहीं हो रहा, ऐसा लगता है ये पढ़ा था 1 दिन पहले, 2 दिन पहले, स्लिप हो गया, उड़ गया, इवेपोरेट हो गया. उसको पढ़ने के बाद एक बार फिर से रिपीट करो, और नहीं हो रहा तो वहीं पे उसको बोलो. जैसे concealed abruption. Abruption occurs in such a way that lower edge of placenta is intact. बोलो इसको. Abruption occurs in such a way that lower edge of placenta is intact. जब हम बोलते हैं ना बेटा, तो थोड़ा समझने की कोशिश करते हैं. लोअर एज ऑफ प्लेसेंटा इंटैक्ट मतलब लोअर एज दरवाजा बंद है, तो ब्लड अंदर से बाहर नहीं जाएगा. हम समझेंगे, पढ़ेंगे, बोलेंगे, साथ में डॉट्स को कनेक्ट करेंगे. जब डॉट कनेक्ट होगा तो हमको रिटेन हो जाएगा. चलो नेक्स्ट क्वेश्चन. A 17-year-old girl. A 17-year-old girl presents with complaints of not attaining menarche. भैया इसको तो महीना आया ही नहीं. 17 साल की बिटिया है, मम्मी के साथ हमारे क्लिनिक में आई है, और मम्मी बोल रही है डॉक्टर साहब मेरी बच्ची को आज तक महीना नहीं आया, उसकी एज है 17, गोला मार दो जी. ठीक है. ग्रॉस एग्जामिनेशन शोड breast and pubic hairs development of Tanner stage 1. Tanner stage 1 and 2 क्या बोलते हैं? जब underdeveloped है. Tanner stage 4 and 5 when they are well developed. So if breast and pubic hairs development is of Tanner stage 1 means they are underdeveloped. ठीक से develop नहीं हुए, और breast और pubic hair अच्छी तरह develop हैं, हमें साफ साफ दिखाई दे रहे हैं, तो हम बोलते हैं Tanner stage 4 and 5. तो इस बिटिया में, 17 साल की छोटी सी बिटिया में, ब्रेस्ट हमको दिखाई नहीं दे रहे, प्यूबिक हेयर्स हमको नहीं दिख रहे, इसलिए हमने बोला टेनर स्टेज 1. अल्ट्रासाउंड कर लिया हमने. अल्ट्रासाउंड एग्जामिनेशन शोज एब्सेंट यूटेरस, सर्विक्स एंड ब्लाइंड वजाइनल एवनिंग. वी डिड ए अल्ट्रासाउंड बट वी कुड नॉट सी एनी यूटरस, सर्विक्स एंड वजाइना. ओके जी, हमने सोचा कैरियोटाइप करा लेते हैं यार, कोई सिंड्रोम तो नहीं है. Karyotyping was requested, which she denied. उसने मना कर दिया. Abdominal examination shows bilateral bulge in inguinal canal. Which of the following is most likely? देखो ऑप्शंस देखते हैं. Mayer-Rokitansky-Kuster-Hauser syndrome. This is MRKH syndrome, and MRKH syndrome signify Mullerian agenesis. MRKH syndrome क्या होता है बेटा? Mullerian agenesis प्लस रीनल एनोमली प्लस स्पाइनल एनोमली. कभी कभी गैलेक्टोसेमिया और ऑडिटरी डिसफंक्शन भी हो जाता है. तो बेसिकली एमआरकेएच सिंड्रोम में मुलेरियन एजेनेसिस है. एजेनेसिस मतलब मुलेरियन डक्ट डज नॉट डेवलप. साथ में एक मोस्ट कॉमन एनोमली कौन सी एसोसिएटेड होती है? रीनल एनोमली, और दूसरी स्पाइनल. तो जब भी ऑप्शन में मेयर-रोकिटेंस्की कुस्टर हॉजर सिंड्रोम लिखा है, इसका मतलब एग्जामिनर किसकी बात कर रहा है? मुलेरियन एजेनेसिस की जगह इंस्टेड ऑफ वर्ड मुलेरियन एजेनेसिस दिस वर्ड मेयर-रोकिटेंस्की कुस्टर हॉजर सिंड्रोम हैज बीन यूज्ड. तो ठीक है भैया, ये एमआरकेएच सिंड्रोम है क्या? अगर ये एमआरकेएच सिंड्रोम होता, तो टेनर स्टेज 1 का कैसे हो जाता? टेनर स्टेज 1 ब्रेस्ट एंड प्यूबिक हेयर डेवलपमेंट, ब्रेस्ट एंड प्यूबिक हेयर डेवलपमेंट। प्यूबिक हेयर डेवलपमेंट तो टेनर स्टेज 1 का क्यों हो जाता, मुझे बस ये बता दो। एक्सिलरी एंड प्यूबिक हेयर, एक्सिलरी एंड प्यूबिक हेयर्स, देयर डेवलपमेंट डिपेंड्स ऑन व्हाट, इनका डेवलपमेंट किस पे डिपेंड करता है, एंड्रोजन। देयर डेवलपमेंट डिपेंड्स ऑन एंड्रोजन। Because their development depends on androgen, androgen receptors are poor in androgen insensitivity syndrome, तो pubic hair वहां पे, axillary hair वहां पे डेवलप नहीं होंगे, मान लिया। अल्ट्रासाउंड में यूट्रस, सर्विक्स और वजाइना एब्सेंट होता है एंड्रोजन insensitivity syndrome में। एंड देयर आर टू क्लूज हियर, bilateral bulge in inguinal canal। बताओ व्हाट डज इट मीन बाइलेटरल बल्ज इन इंग्वाइनल कैनाल, ये क्यों है, बोलो जल्दी से। देखो कौन कौन आंसर कर रहा है। व्हाट इज द रीजन फॉर बाइलेटरल बल्ज इन इंग्वाइनल कैनाल, एंड रीजन फॉर बाइलेटरल बल्ज इन इंग्वाइनल कैनाल कोई बताएगा। अगेन ए चॉकलेट क्वेश्चन, रीजन फॉर बाइलेटरल बल्ज इन इंग्वाइनल कैनाल, बोलो व्हाट इज द रीजन। रीजन, chocolate question, big chocolate question. Reason for bilateral bulge in undescended testis. Wonderful. Samota, your Naveen, Shalini, सागर, किशोर, सबके नाम याद होते जा रहे हैं मुझे। आशा, लक्ष्या, भार्गव, यश, मुकेश, wonderful, wonderful. The reason for bilateral bulge in inguinal canal is undescended testis. So this looks a androgen insensitivity syndrome. Why it is not Turner syndrome? एक बारी देखते हैं। In Turner syndrome, uterus is present but hypoplastic. Turner syndrome is 45XO. Turner syndrome is 45XO. Uterus is present but it is hypoplastic. तो यूट्रस तो एब्सेंट नहीं होगा अल्ट्रासाउंड में, क्लियर सी बात है ना। स्वेयर सिंड्रोम, इन स्वेयर सिंड्रोम में तो यूटेरस होता है, स्वेयर सिंड्रोम में यूट्रस होता है, टर्नर सिंड्रोम में यूट्रस होता है, एमआरकेएस सिंड्रोम में प्यूबिक हेयर नॉर्मल होते हैं। व्हाई दे वुड बी टेनर स्टेज 1? सो आंसर टू दिस क्वेश्चन इज एंड्रोजन इनसेंसिटिविटी सिंड्रोम। अब जरा क्विकली ना मेंस्ट्रुअल साइकिल के 8 सिंगल लाइनर सॉल्व करते हैं, 8 सिंगल लाइनर्स ऑफ मेंस्ट्रुअल साइकिल, एंड दीज आर द चॉकलेट क्वेश्चन। मैं बोलता हूं, my first question to you is identify the hormone labeled as A. बताओ जल्दी से। In this menstrual cycle chart, identify the hormone labeled as A. कौन सा है? This is the chocolate question. Identify the hormone marked as A. कौन सा वाला है? बोलो। A वाला बताओ। Super duper important MCQ for our exam. This image question is given in our exam and examiner just puts a arrow and asks us a question. Identify the hormone marked by the arrow. A. Bolo bolo. Estrogen. Wonderful. Wonderful. Estrogen. Everyone. Superb. How do you find that this is estrogen? Hormone which is maximum in amount before ovulation is estrogen. And ovulation is a mid-cycle phenomena. तो ovulation कहाँ पे होगा? This line indicates ovulation. So hormone labeled as A is estrogen. My next question to you, hormone labeled as D is, जल्दी बोलो, D कौन सा है? Hormone labeled as D. All these are chocolate question. Hormone labeled as D, which one? Please tell me. बताओ। एग्जाम में ऐसे ही आएगा और डी पे एरो मार देगा, बोलो कौन सा है, और सॉलिड एक नंबर मिल जाएगा हमको। प्रोजेस्ट्रॉन, वंडरफुल। ध्रुव, वंदना, रामकिशन, उन्नत, नीलेश, नवीन, वंडरफुल। रुपिंदर, नवी, अविनाश, वंडरफुल। स्वप्निल, सुपर। विधि, वेरी गुड, वेरी गुड। शिवम, सुपर। सो डी इज प्रोजेस्ट्रॉन, दिस इज प्रोजेस्ट्रॉन। माय नेक्स्ट क्वेश्चन टू यू, आइडेंटिफाई द हार्मोन marked as B. Identify the hormone labeled as B. बताओ बेटा B कौन सा है? B कौन सा है? B. Identify the hormone labeled as B. LH. Wonderful, wonderful. This is LH. Very good. Identify the hormone marked as C. Identify the hormone marked as C. C कौन सा है? बोलो। सी कौन सा है बोलो? ये सारे ऐसे सॉलिड क्वेश्चन है along with 25 clinical questions of obs-gynae. I am trying to cover all the important, very important related single liner question. So this 25 questions obs-gynae session may contribute something in your life. That's my sole wish from my heart. अगर मेरी वजह से जिंदगी में थोड़ा सा किसी की कंट्रीब्यूशन हो गया, उसकी दुआएं मेरी तकदीर भी बदल सकती हैं। मेरी इसी इच्छा के साथ मैं इस सेशन को लेने की कोशिश कर रहा हूं। सारे एफएमजी स्टूडेंट पास हो जाएं। जल्दी बोलो सी कौन सा है? एफएसएच। वंडरफुल, सी इज एफएसएच। वेरी गुड, सी इज एफएसएच। चलो जल्दी से 4 और क्वेश्चन। इसका चॉकलेट नहीं खेलेंगे, टाइम बहुत लगेगा बेटा, क्योंकि अभी चौथा क्वेश्चन है, हमको टाइम पे फिनिश भी करना है। अब मैं खुद ही बोल देता हूं, जस्ट लिसन टू मी। ये 4 क्वेश्चन मुझसे ले लो, इनकी चॉकलेट नहीं मिल रही, ठीक? लेवल्स ऑफ एफएसएच आर मैक्सिमम ऑन आंसर डे ऑफ ओव्यूलेशन। क्वेश्चन नंबर 2, लेवल्स ऑफ एलएच आर मैक्सिमम ऑन आंसर डे ऑफ ओव्यूलेशन। क्वेश्चन नंबर 3, लेवल्स ऑफ estradiol आर मैक्सिमम ऑन 36 hours before ovulation. Question number 4, levels of progesterone are maximum on day 22 of cycle or day 8 post ovulation. All of you will read the question very carefully. What is mentioned in the question? If it is day of ovulation, day 8 post ovulation. If it is day of cycle, day 22 of cycle. चलो आगे बढ़ते हैं। Not much time left now. We have to pass on 30th of July. Not much time left now. We have to pass this exam on 30th of July. On 30th of July, whatever the reasons may be, OBG may be game changer. This is why I may take few more minutes to complete this session. My sole wish, pass हो जाए सब लोग। चलो, question number 5. A lady presents with 37 weeks pregnancy. A lady presents with 37 weeks pregnancy with transverse line. What first line of the question gives her? First line of the question gives us that she is presenting with 37 weeks pregnancy. And the second message in the first line of the question is, there are 2 messages in the first line of the question. Message number 1, her gestational age is 37 weeks. Message number 2, her presentation is transverse. क्या बोलता है एग्जामिनर? She is in transverse. She is not in cephalic. She is not in breech. She is having which presentation? Transverse. Which confirmed with ultrasound. हमने अल्ट्रासाउंड भी कर लिया। अल्ट्रासाउंड भी वही बात बोल रहा है जो मैंने अपने हाथ से पता लगा ली थी। What I found with my abdominal examination, the same has been confirmed by ultrasound. Okay. Ultrasound revealed fundoposterior placenta, and we cracked this single liner question in this session only, that most common location of placenta is fundoposterior, and we solved that anatomy and embryology question also. Why most common location of placenta is fundoposterior? Because another important question beta, because most common site of इंटरस्टिशियल इम्प्लांटेशन इज फंडोपोस्टीरियर। एम्ब्रियोलॉजी का क्वेश्चन भी हमने सॉल्व कर लिया। थर्ड लाइन पढ़ते हैं, एमनियोटिक फ्लूइड इंडेक्स इज 18, तो एएफआई एग्जामिनर बोलता है 18 है। एंड मेरे प्यारे प्यारे बच्चे, माय डियर लविंग स्टूडेंट्स, नो वेरी वेल दैट नॉर्मल एएफआई is 5 to 24. So if examiner is using the word that amniotic fluid index is 18, in other way amniotic fluid index is normal. तो भैया amniotic fluid जो पानी अंदर भरा हुआ है वो नॉर्मल है। She delivered twins 2 years back with cesarean section. 2 साल पहले उसकी डिलीवरी हुई थी, 2 बच्चे पैदा हुए और सिजेरियन से हुए। हमको सिजेरियन ऑपरेशन करना पड़ा। What is the next step in her management? Option number 1, induction of labor. What comes to your mind, beta? She is in transverse right now. What is the management for transverse? We have discussed in detail in our classes that management of transverse is, if she is not in labor, we can go for external cephalic version. What is external cephalic version? We do a ultrasound, and under ultrasound guidance, we hold the head of fetus and we bring it down. This is called external, क्योंकि हम अंदर नहीं गए, अंदर जा नहीं सकते, क्योंकि लेबर स्टार्ट नहीं हुआ, सर्विक्स डायलेटेड नहीं है। So we have to manipulate everything externally. So what Vardhan will be done external. We hold the head, bring it down. किसको पकड़ा? सिर को बाहर से पकड़ा तो क्या बोला? एक्सटर्नल. किसको पकड़ा? सिर को. एक्सटर्नल cephalic वर्धन. Management of transverse, if she is not in labor, is external cephalic वर्धन. Management of transverse, if she is in labor, is cesarean section. But if there is history of previous cesarean section, external cephalic वर्धन cannot be done. अगर पहला बच्चा ऑपरेशन से हुआ था, यहां टांका लगा हुआ है, अगर मैंने बच्चे को अंदर घुमाया तो टांका खुल जाएगा. There is risk of uterine dehiscence or uterine rupture. So external cephalic वर्धन cannot be done if there is history of previous cesarean section. If this line was not mentioned here, if the line was she delivered vaginally 1 year back or 2 years back, then answer to this question would have been external cephalic वर्धन. Since this line is mentioned that she delivered previously with cesarean section, इस बच्चे में जरा सिर को घुमाने की कोशिश की, टांका खुल जाएगा, तो हम एक्सटर्नल cephalic वर्धन नहीं कर पाए. Induction of labor is out of question. In transfer, external cephalic वर्धन cannot be done. Wait for spontaneous labor, transverse में कुछ होगा ही नहीं, लोअर यूट्राइन सेगमेंट बनेगा ही नहीं, क्योंकि जब यूट्रस कॉन्ट्रैक्ट करेगा बच्चे को पुश ही नहीं कर पाएगा, बच्चा तो ऐसे है. सिफेलिक होता है तो क्या होता है? यूट्रस कॉन्ट्रैक्ट्स, pushes the fetus down, fetus strikes on cervix. So answer to this question is cesarean section. थोड़ा सा इमेज देख लेते हैं जो मैंने बताया. This is the image question. If this kind of image question is given, transfer. This is how we go for external cephalic वर्धन. We hold the head and bring it down. थोड़ा सा एक इंपॉर्टेंट इमेज क्वेश्चन और देख लेते हैं. कभी कभी ब्रीच के बारे में पूछते हैं. आइडेंटिफाई द टाइप ऑफ ब्रीच. तो कंप्लीट ब्रीच, इनकम्प्लीट और फ्रैंक. मैं वैसे ही बता देता हूं, एक बार मुझे देख लो. लुक हियर, जस्ट हैव अ लुक. फाइन, ब्रीच को देख लो एक बार. ब्रीच इज ऑफ 2 टाइप्स. आधा मिनट में कंप्लीट एंड इनकम्प्लीट. कंप्लीट ब्रीच को फ्लेक्स ब्रीच बोलते हैं. इफ थाइज आर फ्लेक्स्ड एंड नी आर आल्सो फ्लेक्स्ड. विच टाइप ऑफ ब्रीच इज दिस? कंप्लीट ब्रीच और फ्लेक्स्ड ब्रीच. थाई भी फ्लेक्स्ड है, नी भी फ्लेक्स्ड है, सब कुछ फ्लेक्स्ड है, इसीलिए इसको बोलते हैं कंप्लीट ब्रीच. इफ आई एम डूइंग ए पर वेजाइनल एग्जामिनेशन, व्हाट वुड बी पल्पेबल? बटक्स, जेनाइटल, फीट. इनकम्प्लीट ब्रीच इज ऑफ 3 टाइप्स. फ्रैंक ब्रीच और एक्सटेंडेड ब्रीच. देखो क्या होता है, थाइज आर फ्लेक्स्ड बट नी आर एक्सटेंडेड. पर वेजाइनल एग्जामिनेशन विल रिवील बटक्स एंड जेनाइटलिया. फिर देखते हैं नी ब्रीच. Thighs are extended and knee are flexed. PV examination will show knee. This is footling breech. Thigh is extended, knee is also extended. If I am going in vaginally, what I will be able to palpate? Feet. So these are various types of breech. चलो वापस लौट के आते हैं. चलो, one more way, if you are finding difficulty in revision, quickly I will go through everything, because we have to cover 25 questions. If you find some difficulty in revising, just maybe for 30 seconds or maybe for 45 seconds or 1 minute, just record your own video. Just ask your friend to record your video once you are studying. Like you are studying here or you are revising, and you should look at your own video. अपना वीडियो खुद देखो बेटा, और उस वीडियो में देखो मैं कैसे पढ़ रहा हूँ, मैं कैसे रिवाइज कर रहा हूं. पढ़ते हुए और रिवाइज करते हुए मेरी नजर कितनी बार नोट्स से इधर उधर दाएं बाएं डाइवर्ट होती है. एंड चेक योर ओन लेवल ऑफ कंसंट्रेशन. दैट्स द ओनली वे यू कैन असेस योरसेल्फ. एक और तरीका है, आधा घंटा पढ़ने के बाद जस्ट आस्क योरसेल्फ, खुद ही सोचो, यार वर्कबुक को बंद किया, नोट्स को बंद किया, कितना याद हुआ? हाउ मच आई एम एबल टू मेमोराइज? अगर लगता है यार इतना सारा पढ़ा था और मैं याद नहीं कर पाया, एक बार फिर दोबारा से वर्कबुक ओपन करो, मोबाइल को साइलेंट पे डाल के दूर रख दो, सारे डिस्ट्रैक्शंस रूम में खत्म करो. जितना ज्यादा कंसंट्रेशन से पढ़ाई करोगे उतना ज्यादा रिटेन होगा. लेट्स मूव टू अनदर क्वेश्चन. अ लेडी प्रेजेंट्स विद प्रोलॉन्ग्ड लेबर. शी इज प्रेजेंटिंग विद prolonged labor. Her last baby was delivered by lower segment cesarean section 2 years back. Fine. Suddenly she start complaining of pain in previous cesarean section scar area. ओके जी, इतनी लाइन से हमको अभी मैसेज क्या मिल रहा है? एक लेडी आई है, उसकी लेबर प्रोलॉन्ग हो गया, बहुत टाइम लग रहा है लेबर में बेटा. शी इज इन लेबर रूम एंड द लेबर इज प्रोलॉन्ग, बहुत टाइम लग रहा है. हर लास्ट बेबी वाज डिलीवर्ड बाय LSCS. 2 साल पहले एक बच्चा हुआ था, ऑपरेशन से, सिजेरियन से हुआ था. सडनली शी स्टार्ट कंप्लेनिंग ऑफ पेन इन प्रीवियस सिजेरियन सेक्शन स्कार. 2 साल पहले एक बच्चा हुआ, सर्जरी से हुआ, LSCS. नाउ शी स्टार्ट कंप्लेनिंग ऑफ, क्या बोल रही है? डॉक्टर साहब टांकों में दर्द हो रहा है. डॉक्टर साहब टांकों में दर्द हो रहा है. शी इज फीलिंग पेन इन स्कार एरिया. ऑन एब्डोमिनल एग्जामिनेशन उसने बोला डॉक्टर साहब यहाँ पे दर्द है, यहाँ टांका लगा था ना, स्कार एरिया. मैंने अपना हाथ लगाया. जो वो बोलती है उसको बोलते हैं सिम्टम, जो मैं देखता हूँ उसको बोलते हैं साइन. मैंने वहीं पे हाथ लगाया जहां उसने मुझे दर्द बताया. जब मैंने हाथ लगाया बोली डॉक्टर साहब ओ बहुत तेज दर्द है. इसको बोलेंगे स्कार टेंडरनेस. जो मैंने देखा उसको बोला स्कार टेंडरनेस, जो उसने बताया वो सिम्टम था, दैट वाज पेन. स्कार टेंडरनेस इज प्रेजेंट, यहां पे दर्द है. फीटल हार्ट रेट इज 190 बीट्स पर मिनट, विच ऑफ द फॉलोइंग इज मोस्ट लाइक. देखो क्या हो रहा है. इस क्वेश्चन में हमको मैसेज मिल गया, लास्ट डिलीवरी सिजेरियन से हुआ था, इस बार उसका लेबर प्रोलॉन्ग हो गया. प्रोलॉन्ग लेबर के कारण ही, क्योंकि बहुत स्ट्रेन आ रहा है यूट्रस पे, टाका खुलने लगा. चलो, इसीलिए उसको पेन हो रहा है और इसीलिए स्कार टेंडरनेस है. द फीटल हार्ट रेट इज 190 बीट्स पर मिनट. नॉर्मल FHR वी ऑल नो इज 110 to 160 beats per minute. Normal fetal heart rate is 110 to 160 beats per minute. So what is happening in this condition? There is fetal tachycardia. क्या हुआ बेटा? बच्चे की हार्ट रेट बढ़ गई. बच्चे की हार्ट रेट बढ़ गई, fetal tachycardia. And we know pain in scar area, scar tenderness and fetal tachycardia. Fetal tachycardia is the most consistent sign of uterine dehiscence. और यूट्राइन डेहिसेंस और यूट्राइन रप्चर में फर्क क्या है बेटा? यूट्राइन रप्चर मतलब यूट्रस फट गया, यूट्राइन डेहिसेंस मतलब यूटेरस फटने वाला है. तभी तो बोलते हैं ना, यूट्राइन रप्चर ऑल लेयर्स ऑफ यूट्रस आर सेपरेटेड इंक्लूडिंग सिरोसा. यूट्राइन डेहिसेंस ऑल लेयर्स ऑफ यूट्रस आर सेपरेटेड एक्सेप्ट सिरोसा, दैट इज इंटैक्ट. तो ये यूट्राइन डेहिसेंस का मामला लग रहा है. अब ऑप्शंस देखते हैं. ऑब्स्ट्रक्टेड लेबर. If it was a case of obstructed labor, why she will complain of pain in scar area? Why there will be scar tenderness and why there will be fetal tachycardia? All these things do not match with obstructed labor. If this question was related to obstructed labor, listen to me very carefully beta. Clinical questions को solve करना सबसे easy है. To solve clinical questions is very easy and in fact, clinical sense, clinical essence, clinical vignettes have been my cup of tea throughout the life. मुझसे तो जिंदगी में कभी कुछ रटा ही नहीं गया. Connecting the dots had been my passion. Obstructed labor अगर होता तो इसका क्वेश्चन बनाते हैं. जल्दी से सुनो, जल्दी जल्दी करेंगे. Let's frame the question of obstructed labor. If examiner will frame a question related to obstructed labor, what keywords examiner will put in the question? Examiner may put that she is trying her level best to deliver, but there is a ring palpable at the junction of upper and lower segment, that is Bendel's ring or retraction ring. तो एक कीवर्ड क्या देता? कोई बेंडल्स रिंग या रिट्रैक्शन रिंग लिखता, हिमेचूरिया लिखता. ऑब्स्ट्रक्टेड लेबर में हिमेचूरिया, माइल्ड वजाइनल ब्लीडिंग, शी इज वेरी एग्जॉस्टेड, वो कुछ नहीं लिखा. एब्रप्शियो प्लेसेंटी अगर होता, एब्रप्शियो प्लेसेंटी का क्वेश्चन कैसे बनेगा? बनाते हैं बेटा. एब्रप्शियो प्लेसेंटी एक क्वेश्चन सॉल्व किया था ना, हाइपरटेंशन था हमारे क्वेश्चन में. एक और बड़ा कॉमन रिस्क फैक्टर होता है एब्रप्शियो में, ट्रॉमा. एग्जामिनर में पुट दैट शी मेट ए कार एक्सीडेंट और शी मेट ए बाइक एक्सीडेंट. देन दूसरा कीवर्ड जल्दी से रिकॉल करो, सडन पेन इन एब्डोमेन. फिर साइन देखो, पेन तो उसने बताया, हमने क्या पाया? हमने पाया फीटल हार्ट साउंड नॉट ऑडिबल, फीटल पार्ट नॉट पाल्पेबल, एब्डोमेन हार्ड एंड टेंडर, एब्रप्शियो प्लेसेंटी। ऐसा कुछ नहीं लिखा तो ये आंसर नहीं है। यूट्राइन रप्चर, if it was a case of uterine rupture, what is seen in uterine rupture? Fetal bradycardia। देखो ये दोनों ऑप्शंस ना थोड़े क्लोज हो गए, या मामला जरा करीब आ गया। यूट्राइन रप्चर एंड यूट्राइन डाइसेंस, लेट्स डाइसेक्ट दीज टू ऑप्शन। इन यूट्राइन रप्चर देयर अकर फीटल ब्रेडिकार्डिया। अभी बताया था ना, यूट्राइन डाइसेंस मतलब यूट्रस फट, सुपर डुपर इंपॉर्टेंट एरिया फॉर अवर एग्जाम। यूट्राइन डाइसेंस मतलब यूट्रस फटने वाला है, अंदर बच्चा लड़ रहा है तो फीटल हार्ट रेट इंक्रीज। सो यूट्राइन डाइसेंस में क्या होता है? फीटल टैकीकार्डिया। जब यूट्रस फट गया, बच्चे ने हैंड्स अप बोला, fetal heart rate decrease means fetal bradycardia, and finally fetus will die. So uterine rupture means fetal bradycardia, uterine dehiscence means fetal tachycardia. So answer to this question is uterine dehiscence. थोड़ा सा इमेज से कोरिलेट कर लेते हैं क्विकली। This is the scar tissue because there is a history of previous cesarean section. So this is the scar tissue, and as you can see, this is the normal scar. No layer is separated, no uterine layer is separated. Let's compare this normal scar with scar dehiscence. Let's have a look. This is scar dehiscence, and you can see here, all the layers of uterus have been separated except the outermost layer of uterus, serosa is intact. Now again compare uterine dehiscence with normal scar. See, all layers of uterus was intact here. कोई भी फटी नहीं थी बेटा, सारी की सारी लगी हुई थी. And see the uterine dehiscence. All layers of uterus have been separated except the outermost layer, uterine serosa. And compare with uterine rupture, scar rupture. All the layers of uterus have been separated including the serosa. If this kind of image is also given, सब कुछ फट गया मतलब rupture है, outermost layer intact है मतलब uterine dehiscence. This is again an image of uterine rupture, uterus फट गया, and you can see the fetal head here. ठीक है? What is this image? This is the image of covalular uterus. Quickly image भी revise करते चलते हैं. Covalular uterus which is seen in abruptio placentae. Again an image of covalular uterus, bluish red uterus, wine colored uterus. ठीक है? और ये कौन सी इमेज थी? क्विकली फिर से रिवाइज कर दो. यूट्राइन प्लेसेंटल एब्रप्शन. देखो दोबारा से बता देता हूं, प्लेसेंटा प्रेविया का तो कई बार पूछ लिया, अब एब्रप्शन का कभी भी पूछ सकते हैं. ये प्लेसेंटा है, यूट्राइन वॉल से हट गया. This placenta has been detached from uterine wall. So this is the image of placental abruption. Why I am showing it again? Because image of placenta previa has been asked multiple times. Question in waiting is image question of abruptio placentae. Develop thinking habit बेटा. बड़े दिन से ना शोर हो रहा है और बच्चे भी कह रहे हैं सर ने जरा सी भी बात नहीं की. शोर मचाया हुआ है लोगों ने, पता नहीं इतना शोर मचाया हुआ है, इतना ऊधम मचाया हुआ है. कभी कभी यार 1 मिनट लूंगा, बात को ध्यान से सुनना. मेरी समझ में ये नहीं आता, आई एम नॉट एबल टू अंडरस्टैंड. द टाइम इज सो प्रेशियस. द स्टूडेंट्स आर जस्ट गोइंग टू फेस द एग्जाम, whatever the exam is, maybe a FMGE exam or a NEET PG or whatever they are, or a INI set, whatever it is. The time is so precious, and students should devote their energy and time in studying and revising. How a student can afford to go through various channels, various stuff, and listen to everything? And the crux message and the core message is same. क्या हम इतने समझदार नहीं हैं? क्या हमारी इतनी समझ में नहीं आता? हम इतना सारा टाइम वेस्ट करेंगे? मत करना बेटा, मत करना. Don't listen to anything. Our exam, FMG exam will happen on 30th of July. Our FMG exam will happen in December. Don't just, but what we have been seeing in last few years, that question पेपर पैटर्न हैज बीन चेंजिंग. इतना हमको भी पता है यार कि अब वो नहीं पूछते मोस्ट कॉमन कॉज ऑफ दिस, मोस्ट कॉमन कॉज ऑफ दिस. क्वेश्चंस हैड बिकम क्लिनिकल. तो हम क्लिनिकल क्वेश्चंस करने के अच्छे हैबिचुअल हैं, हमको क्लिनिकल क्वेश्चंस करना आता है. क्लिनिकल क्वेश्चंस आर वेरी इजी टू क्रैक बिकॉज यू गेट टू मेनी क्लूज ना. एक 5-6 लाइन का क्वेश्चन है यार, उसमें इतने सारे क्लू हैं. कहाँ पे दर्द है ये लिखा है, अल्ट्रासाउंड में क्या मिला ये लिखा है, ब्लड टेस्ट की रिपोर्ट लिखी है, सब कुछ तो लिखा हुआ है. फैक्चुअल क्वेश्चन इज रियली डिफिकल्ट टू क्रैक. आता है तो आता है, नहीं आता तो नहीं आता, नहीं पता तो नहीं पता. यहां तो जरा डॉट्स को कनेक्ट करके हम आंसर ले सकते हैं. तो डेवलप थिंकिंग हैबिट, केवल सोचने की हैबिट डेवलप करना है. नेक्स्ट एग्जाम इज जस्ट अबाउट being aware of what are you studying. All the FMGs will take FMG exam on 30th July. All the FMGs will take FMG exam in December. The only thing is questions may become little clinical. What are you thinking? How are you connecting the dots? That is going to matter. Even in this transition phase, in last couple of years, we have seen, and we have been seeing, change in question paper pattern. So we all FMG students have become habitual. And believe me, if next exam comes maybe after 1 year or whatever it is, or 2 years or 3 years, whatever, it may come any time after December, that's for sure, after December any time, maybe, may not be, FMG exam soon will top that next one exam. और मेरी दिल से इच्छा है, एक FMG एग्जाम जिस दिन भी नेक्स्ट एग्जाम आएगा, FMG स्टूडेंट नेक्स्ट एग्जाम को टॉप करेगा, और वो दिन मेरी जिंदगी का सबसे खुश वाला दिन होगा, सबसे खुशी का दिन होगा. एंड FMG student can easily get rank 1 in a next exam. The only thing is we have to develop a thinking habit. Why I am saying so? Because we have been struggling for last 5 or 6 years. We lived in those unfavorable conditions where it is not even evil to live. इतनी ठंड में भी रहे हम, अपने आप कैसे कैसे खाना खाया हमने, कभी मिला कभी नहीं मिला, इतनी एडवर्स कंडीशंस को क्रॉस करके हम यहाँ तक आ गए. सो FMG स्टूडेंट विल डेफिनेटली गेट द रैंक 1 इन नेक्स्ट वन एग्जाम, एंड इट विल नॉट हैपन वंस ओनली, इट विल हैपन मल्टीपल टाइम्स, एंड आई विल ट्राई माई लेवल बेस्ट, एंड आई पर्सनली टेक द रेस्पॉन्सिबिलिटी फॉर दिस. I will request all the faculty to work doubly hard, and all the faculties are so nice कि वो डबल मेहनत करेंगे, जिससे कि एक FMG स्टूडेंट अगर नेक्स्ट एग्जाम कभी भी आता है, जब भी आएगा, 1 साल बाद, 2 साल बाद, 3 साल बाद, तो वो उसको टॉप करेगा. चलो नेक्स्ट क्वेश्चन. अ कपल प्रेजेंट्स विद, थोड़ा जल्दी करते हैं यार, टाइम लग रहा है, जल्दी से करते हैं. अ कपल प्रेजेंट्स विद इनफर्टिलिटी इन योर इनफर्टिलिटी क्लिनिक. They are living together for last 2 years. Seminogram was requested, which was found to be normal. तो एक कपल आया, पहली लाइन का मैसेज सुनो. कपल presents with infertility. Their problem is infertility. They present in your infertility clinic. They are living together for last 2 years. Seminogram was requested, which was found to be normal. First investigation advised in an infertile couple is seminogram, and this seminogram is normal. She was advised hysterosalpingography, which revealed bilateral cornual block. Okay ji. Serial ultrasound ovulation studies showed that cycles are regular and ovulatory. Which of the following is most likely cause of infertility in this couple? So what is the message in this question? In the 7-liner question, this is the 7-liner question. The problem is infertility. Couple is staying together for 2 years. And infertility word is used if a couple is not able to conceive even after 1 year of staying together. And the first investigation advised in an infertile couple is seminogram, which already has been done and which is normal. The only problem is a hysterosalpingography, which is revealing the bilateral cornual block. So the message in this 7-liner question is, भैया मियाँ बीबी आए, हमारे क्लिनिक में आए, बोले जी 2 साल से साथ रह रहे हैं, बच्चा नहीं हो रहा. पहले हमने सीमेन एनालिसिस करा लिया, क्योंकि हमें फर्स्ट MCQ भी मालूम है. We know that important single liner also, that first investigation advised in an infertile couple is seminogram. उसकी रिपोर्ट आ गई नॉर्मल. फिर हमने फीमेल को इवेल्युएट करना स्टार्ट किया. वी रिक्वेस्टेड HSG एंड द रिपोर्ट सेड बायलेटरल कॉर्नुअल ब्लॉक. हमने अल्ट्रासाउंड से फॉलिकुलर मॉनिटरिंग कर लिया, जिसको ओव्यूलेशन स्टडीज कहते हैं, जिसमें हम कई बार अल्ट्रासाउंड के लिए बुलाते हैं, एंड वी चेक फॉर ओव्यूलेशन, एंड वी फाउंड दैट ओव्यूलेशन इज हैपनिंग इन हर. तो मतलब ओवरी तो नॉर्मल है, ओवेरियन फैक्टर नॉर्मल है, पंगा फैलोपियन ट्यूब में है. फाइन. Which of the following is most likely cause of infertility? Endometriosis. Why it cannot be endometriosis? No clinical keyword related to endometriosis is given in question. Listen to me very, very carefully, beta. If the answer was endometriosis, what clinical keywords you could find in the question? The clinical keywords in the question could be, most common symptom in endometriosis is dysmenorrhea. If the answer was endometriosis, examiner has to put the word dysmenorrhea in the question. Examiner has to put the word dyspareunia in question. Dyspareunia means pain during intercourse. Dysmenorrhea means pain during menses. Two clinical keywords, dysmenorrhea, dyspareunia, missing in this question. It cannot be endometriosis anyway. Ruled out. No dysmenorrhea, no dyspareunia. And moreover, in endometriosis, ovulation is also not normal. Fine. Polycystic ovarian syndrome. If answer to this question was polycystic ovarian syndrome, what clinical keywords you could find in the question? Symptom in PCOS. If the girl was having PCOS, there is tendency for obesity. Nowhere obesity clinical keyword is mentioned. In polycystic ovarian syndrome, there is an ovulation. And here ultrasound ovulation studies are normal. They are clearly saying that ovulation is happening in her. In PCOS, there is an ovulation, no obesity word mentioned, no an ovulation word mentioned, no acne, no hirsutism, no androgenic alopecia. Nothing is mentioned. It cannot be PCOS anyway. Pelvic inflammatory disease with tubal block. The problem is tubal block, bilateral cornual block. It can be the answer, beta. Listen to me very carefully. It can be the answer. But we are in habit of reading all the options till last word. And the option D is genital tuberculosis. If you compare the option C and option D, why the answer is option D? Because in genital tuberculosis, which end of fallopian tubes are commonly blocked? Cornual end. This is the uterus and this is fallopian tube. Which end of fallopian tubes are commonly blocked in genital tuberculosis? Cornual end. While in gonorrhea and chlamydia, femoral ends are blocked. So between C and D, why answer is genital tuberculosis? Because bilateral cornual block word is mentioned in the question. So answer to this question is genital TB. Let's go through few images quickly, beta. मैं थोड़ा सा चॉकलेट थोड़ी देर में खेलेंगे, पहले पास होना जरूरी है. जल्दी जल्दी काम की बातें करते हैं. If this kind of image is given, this is a bilateral femoral block. Look, what is this? This is Leach-Wilkinson cannula, through which we instill which dye? Urographin. This is normal uterus. This is fallopian tube. This is fallopian tube. But if you compare this hysterosalpingography with that one, a normal HSG, what is the difference? In normal HSG, there was a spill of dye. There is no spill of dye. Dye is not coming out of femoral end. So this is the case of bilateral femoral block. क्योंकि बेटा dye femoral end के बाहर नहीं आई. कहीं भी बाहर आती हुई नहीं दिख रही. अगर डाई फिम्ब्रियल एंड के बाहर आती है, हम कहते हैं स्पिल ऑफ डाई. So this is the case of bilateral femoral block. This has been mentioned in our question that she is presenting with bilateral cornual block. देखो compare करो बेटा. This is uterus and you can see dye is not even able to pass beyond the cornual end. So this is the case of bilateral cornual block and most common site of cornual block is genital tuberculosis. ठीक है ना बेटा? This is the laparoscopy image. Laparoscopic chromoperturbation is the best investigation to identify tubal block. And what is the best day to conduct laparoscopic chromoperturbation? Day 10. PID में किया day 10 पे. This is the image of ovum pickup. This is the image for ovum pickup in IVF. We can see the needle which is going in ovarian follicle. This is the image of ICSI, intracytoplasmic sperm injection. You can see we are injecting single sperm in the cytoplasm of oocyte. ये oocyte है बेटा, and we are injecting one sperm. We inject one sperm directly into the cytoplasm of oocyte. This is called intracytoplasmic sperm injection. And this intracytoplasmic sperm injection is done if there is asthenospermia, severe oligospermia or obstructive azoospermia. And this is in vitro fertilization image where we are picking up oocytes and we put the oocyte in petri dish, and how many sperms are dropped per oocyte? 50,000 to 1 lakh sperms are dropped per oocyte. If the answer was endometriosis, let's quickly revise the images of endometriosis. This is ultrasound image of endometriosis, and what is the name of appearance? Ground glass appearance. This is called ground glass appearance. So this is an important image question. This is the ovarian cyst, and this ground glass appearance of ovarian cyst is seen in endometriosis. But what clinical keywords you could find if answer was endometriosis? There could be dysmenorrhea or dyspareunia. And examiner sometimes may put the word progressive dysmenorrhea or progressive dysmenorrhea. Progressive मतलब बढ़ रहा है बेटा, क्योंकि हर बीतते हुए वक्त के साथ, हर बीतते हुए महीने के साथ बीमारी की सीवियरिटी बढ़ती है. तो कौन सा वर्ड लिख देते हैं? प्रोग्रेसिव डिस्मेनोरिया या प्रोग्रेसिव डिस्पेरियोनिया. This is the laparoscopy image of endometriotic cyst. Again a very important image question. This is chocolate cyst. So chocolate cyst is seen during laparoscopy. This is again an image for endometriosis. This is gunshot or powder burn appearance. As you can see, these are deposits of endometrium in peritoneal cavity. This is a gunshot or powder burn appearance in endometriosis. This is the Allen-Master syndrome, which we have discussed in our classes in detail. If there is break in ligaments, you can see the ligament. When these deposits fall in peritoneal cavity, due to weight of these endometriotic deposits, there can be break in the ligament. And if this ligament is ruptured here, as you can see, this condition is called Allen-Master syndrome. So Allen-Master syndrome is seen in which disease? Endometriosis. What is Allen-Master syndrome? Break in ligaments due to weight of endometriotic deposit. If the answer was PCOS, there were no clinical keywords like obesity, acne, hirsutism, etc. But this is again an important image question of PCOS. If this kind of image is given, what is this ultrasound sign called as? This is called necklace sign or string of pearls sign. As you can see, all the follicles have been displaced towards periphery with the thick stroma in the center. This is the thecal hyperplasia, which is responsible for displacement of all the follicles towards periphery. This necklace sign or string of pearls sign is seen in PCOS. So this is the image question of PCOS, but no clinical keyword of PCOS has been mentioned in the question. This is the gross image of polycystic ovary. If by chance this image is given in exam, we will find no difficulty in finding the condition that this is the case of polycystic ovarian syndrome. Next question. A 20-year-old girl presents with primary amenorrhea. She presents with primary amenorrhea with complaints of cyclical pelvic pain every month. So she is having pelvic pain every month. Pain is most severe with commencement of menstruation and on first day of menses. Per abdominal examination is normal. Ultrasonography is done, which concludes normal uterus and adnexa. What is the most likely diagnosis? देखो अब क्या हो रहा है. She is presenting with primary amenorrhea, with complaints of cyclical pelvic pain every month. So she is complaining of pain, but her first two lines gives us the message that she is having pain in pelvis every month, but she is not menstruating. Because the word primary amenorrhea has been mentioned in the question, means blood is not coming out of vagina, but she is having cyclical pelvic pain, means pain is happening. Pain is most severe with commencement of menstruation and on first day of menses. Per abdominal examination is normal. Ultrasonography is done, which concludes normal uterus and adnexa. What is most likely diagnosis? So although she is saying that she is not menstruating, but she tries to say that I am feeling maximum pain during first day. So she assumes that she is menstruating, but blood is not coming out. Ultrasonography shows normal uterus adnexa. What is the diagnosis? It should be a case of cryptomenorrhea. Why it is not Mittelschmerz beta? If it was a Mittelschmerz is mid-cycle pain. And in this question, cyclical pain is mentioned. So Mittelschmerz is gone because Mittelschmerz is mid-cycle pain. Why it is not primary dysmenorrhea? In primary dysmenorrhea, there cannot be the word primary amenorrhea. There cannot be the word primary amenorrhea. This first day of menses word has been mentioned just to confuse you that she feels maximum pain during the first day. Endometriosis. Again, in endometriosis, she will have dysmenorrhea and dyspareunia. Dysmenorrhea and dyspareunia. So, answer to this question is cryptomenorrhea, and most common cause of cryptomenorrhea is imperforate hymen. Again, a very important question for our exam. This image was very, very important. Few other images related to our exam which are important. This is Asherman syndrome, which is again important. Asherman syndrome is formation of fibrous bands or adhesions in endometrial cavity. This is the ultrasound image of Asherman syndrome. This is the endometrial cavity. This is saline infusion sonography, which is also called sonohystrography, where we put the saline in endometrial cavity and then we do ultrasound. You can see these are the fibrous bands here. These are fibrous bands, which are visualized beautifully after instilling the saline. This is the hysterosalpingography of Asherman syndrome. Again, very important image question for our exam, and the question was asked 2 sessions back. This same HSG image was given in our exam, and the question was identify this HSG image. The answer to this question is Asherman syndrome. As you can see in this HSG image, in this uterus, you can see multiple irregular filling defects. Multiple irregular filling defects. So this is HSG Asherman syndrome. At the same time, I am trying to cover maximum question. That is the hysteroscopy image of Asherman syndrome. As you can see, numerous fibrous bands in uterine cavity. So this is hysteroscopy of Asherman syndrome. This is hysterosalpingography of Asherman syndrome. This is ultrasound image of Asherman syndrome, and this is the image of imperforate hymen, and this is the image of cruciate incision on hymen, which is given to treat imperforate hymen. So answer to this question was cryptomenorrhea. Next question. Bringing your awareness to your breathing. Let me tell you once again, if you just bringing your awareness to your breathing makes you aware of what you are thinking and doing. Like this. Just be aware of your breathing, just be aware. Breath is going in, breath is going out. If you just be aware of your breathing for 15 minutes every day, you will start memorizing like anything, and you will have beautiful recalls in examination hall. Just be aware of your breathing. Breath is going in, breath is going out. Next question. You are posted in minimal invasive surgery unit of gynecology department. You can go with laparoscopic surgery for all of the following conditions in operation theatre list except. So the question says you can do laparoscopy for all of the following except. So the basic concept beta is laparoscopic surgery can be done for the pathologies which are outside uterus. And hysteroscopy means camera of uterus. Hysteroscopy can be done for the pathologies which are inside uterus. This question was asked on 5th March 23 in this NEET PG. What is the best method to diagnose the pathologies of uterine cavity? So pathologies of uterine cavity beta means pathologies which are inside uterus can be best seen with camera of uterus, and camera of uterus is hysteroscope, while pathologies which are outside obviously can be best seen with camera of abdominal cavity, which is hysteroscope. बड़ी सिंपल सी देसी भाषा में बात बेटा, यूट्रस के अंदर का किससे दिखेगा? यूट्राइन कैविटी का, यूट्रस के कैमरा से, और यूट्रस के कैमरा का नाम हिस्टेरोस्कोप। यूट्रस के बाहर का किससे दिखेगा? लेप्रोस्कोप से, जो एब्डोमिनल कैविटी का कैमरा। अब हमारी ओटी लिस्ट में वी कैन गो फॉर लेप्रोस्कोपी फॉर ऑल एक्सेप्ट subserous fibroid. Yes, we can do laparoscopy because subserous fibroid is outside. Subserous fibroid is outside. Endometriosis, again we can do laparoscopy because in endometriosis there is ovarian cyst, gunshot appearance, adhesions, we can do lapro. lepro can be done. Polycystic ovarian syndrome, this question was asked in our exam in last session, and the question was about laparoscopic ovarian drilling. A laparoscopic ovarian drilling is done to burn that thecal hyperplasia. So lap can be done. But septate uterus is inside uterus. So for septate uterus, what would be done? Hysteroscopy. Very simple. जल्दी से quickly देख लेते हैं, एक रिवीजन कर देते हैं, quickly करेंगे. So this is the FIGO classification of fibroid. Type 0 fibroid, completely in uterine cavity. Type 1, more than 50% in uterine cavity. Type 2, less than 50% in uterine cavity. 3 and 4 intramural, 3 is touching endometrium. 5, 6, 7 subserous. 5 more than 50% in myometrium. 6 less than 50% in myometrium. 7 outside serosa. And 8 is extrauterine. This question has been asked in NEET PG 3 years back. Identify the given specimen. And the answer was, identify the given hysterectomy specimen. Answer was multiple uterine fibroid. So these are multiple uterine fibroid. Identify the given hysterectomy specimen. Another very important question, identify the given hysterosalpingography image. So this hysterosalpingography image is of submucous fibroid. You can see a laddu in uterine cavity. So in cases of submucous fibroid, in hysterosalpingography we see solitary regular filling defect. While in Asherman syndrome in HSG we see multiple irregular filling defect. Fine. This is a hysteroscopy image of a submucous fibroid. As you can see here, there is a laddu here. So this is the laddu in uterine cavity, and this is the hysteroscopy image of submucous fibroid. Again, let's compare with the hysteroscopy image. This is septate uterus, and this is ultrasound image of a submucous fibroid, and which ultrasound is done to identify the pathologies of uterine cavity. This is a saline infusion sonography, which is also called sonohysterography. Means we put saline in uterine cavity, any fluid in ultrasound appear black. So this is the fluid which appear black, and the pathologies in cavity appear white. I repeat this line. Fluid in ultrasound appear black, pathologies in uterine cavity appear white, means echogenic, black means anechoic. So these echogenic or hyperechoic pathologies are visualized in a better way if we create a black contrast. This ultrasound is called saline infusion sonography, which is also called sonohysterography. So which ultrasound is best to visualize the pathologies of uterine cavity? This is called saline infusion sonography or sonohysterography. I am trying to take this session in little detail just because personally my intuition is this subject may be the game changer in the coming exam. This is the image of laparoscopic ovarian drilling. This question was asked in last session, laparoscopic ovarian drilling, and this is used to treat polycystic ovarian syndrome. You can see this ovary is polycystic. And this is the gross image of various types of fibroid. If this kind of image is given, we can easily identify that this is the intracavitary fibroid, this one. These are inside the myometrium, as you can see. So this is the intramural fibroid, and if examiner puts an arrow like this and identify the type of fibroid in the given image, this is subserous fibroid. How will you identify this is subserous? It is protruding out of uterine serosa. How will you identify this is intramural? It is inside myometrium. How would you identify this is intracavitary? You can easily see it is protruding inside uterine cavity. Fine. And this was the image related to endometriosis, where you can see multiple deposits here. Next question. A lady presents at 36 weeks gestation with complaints of lightheadedness. NEET PG question, it was asked on 5th of March 23. I have little deviated the question, little modified the question. A lady presents at 36 weeks gestation with complaints of lightheadedness and dizziness when she lies on her back. She is comfortable when she lies on her side. Which of the following statements is correct? Now just have a look at the image. the lady, if she is lying in supine position, if the lady is lying in supine position, she is complaining of lightheadedness and dizziness. देखो अपना सिर पकड़ के लेटी हुई है, अगर वो सीधी लेटती है उसके सिर में दर्द है, डिजीनेस हो रही है. And once she turns on side, अगर यही लेडी करवट लेके लेटती है तो उसको कोई प्रॉब्लम नहीं है. She does not feel lightheadedness, she does not feel dizziness if she turns in lateral position. क्या दिमाग में घुसा? What comes to our mind? What is happening to the lady? Look here again. If the lady lies in supine position, what is compressed? Inferior vena cava. Inferior vena cava is compressed, which is leading to decreased venous return, which is leading to these symptoms, lightheadedness and dizziness. This is why a pregnant lady is advised to lie in lateral position. And which lateral position? Left lateral. Why a pregnant lady is advised to lie in left lateral position? Because during pregnancy, uterine enlargement is more towards right side, which is called asymmetric enlargement of uterus, which is Piscaseck sign. So pregnant lady is advised to lie in which lateral position? Left lateral position. Let's see the option. It is due to, or which of the following statement is incorrect? It is due to inferior vena cava compression. It is the correct statement. This is correct. It is supine hypotension syndrome. Correct. This is called supine hypotension syndrome. When a pregnant lady turns from lateral position to supine position, her blood pressure falls due to decreased venous return. This is called supine hypotension syndrome, which happens normally. Pregnant lady is advised to lie in left lateral position. Correct. The question is accept. It is concluding pregnancy-induced hypertension. No. This is a normal phenomena, beta. When a pregnant lady turns from lateral position to supine position, she definitely feels lightheadedness and dizziness due to hypotension, which is called supine hypotension syndrome. So supine hypotension syndrome is a normal phenomena in pregnancy. What is predictor of pregnancy-induced hypertension? Predictor of pregnancy-induced hypertension is supine hypertension syndrome. And this test is called giant rollover test. So this is the answer to question. But the best way to predict pregnancy-induced hypertension is uterine artery color Doppler. I will just tell in 30 seconds the best method to predict pregnancy-induced hypertension is uterine artery color Doppler. In all non-pregnant females and in pregnancy up to 22 weeks of pregnancy, this is the waveform of uterine artery color Doppler. And in uterine artery color Doppler, there are two peaks. One is systolic peak, other one is diastolic peak. With advancing pregnancy, in a normal pregnancy, this diastolic notch disappears. This is the diastolic notch. This disappears after 22 weeks, like this. And the uterine artery waveform becomes like this, where you can clearly see there is disappearance of diastolic notch. Persistence of diastolic notch, even after 22 weeks of pregnancy, is the best predictor of PIH today. Fine. Let's move to. थोड़ी सी बात, ज़्यादा बातें बहुत ज़्यादा इसलिए नहीं करूँगा क्योंकि सिलेबस थोड़ा सा OBG का थोड़ा सा अब चेंज मुझे दिख रहा है. दुनिया जहाँ इधर उधर YouTube पर सबसे पूछ रहे हो क्या करें, कैसे पढ़ें, इतने मैसेज आए मेरे पास, इतने मैसेज आए. I received so many messages, I could not even reply many. Sir, next is coming, what will happen? Sir, next has come, what will happen? भैया, पहले तो मेरी ये समझ में नहीं आता. Nobody will go through any news, any bulletin, any channel, anybody is speaking about next exam. Any FMG who is taking the exam on 30th of July or December FMG. No one will even listen to them. एक मिनट बात करता हूँ. लोग तो बोल देते हैं यार, बच्चे का टाइम खराब होता है. यार इतने दूध पीते बच्चे हैं क्या? एक ही बात को बताने के लिए बार बार एक ही बात को आधा घंटा 1 घंटा बोल बोल के टाइम खराब करना. पढ़ो, 28 days left. रीड, रिपीट, स्पीक आउट, RRS फॉर्मूला, रीड, रिपीट, स्पीक आउट। जो अब तक पढ़ा है उसी को बार बार पढ़ लो, गेम चेंज हो जाएगा। ऐसे पास हो जाएंगे, ऐसे सब ऐसे पास होंगे, बिल्कुल इस तरह से पास होंगे। गेम को चेंज कर देंगे हम। रीड, रिपीट, स्पीक आउट, रीड, repeat, speak out. Nobody will listen to any news. Nobody will go to any channel, any platform, listening anything about next. You have to promise me. और हम सब मिलकर चॉकलेट पार्टी करेंगे एग्जाम में पास होने के बाद, बिकॉज वी ऑल विल पास इन एग्जाम इफ वी रीड, रिपीट, स्पीक आउट, इफ वी रीड, रिपीट, स्पीक आउट व्हाट वी हैव ऑलरेडी स्टडीड। जो अभी तक पढ़ा है उसी को दोबारा पढ़ना है, हमारा एग्जाम पास हो जाएगा। और एक भी चैनल पे फालतू की बात सुनी जो केवल दिमाग का दही बना रही है, कुछ नहीं होने वाला। खुद से पूछो यार, कोई तुमको क्या बताएगा तुम्हारा क्या होना है? खुद तुम अपने आप से पूछने की कोशिश करो, जवाब मिलेगा 30 जुलाई को FMGE एग्जाम में। पढ़ ले, दिसंबर में FMGE एग्जाम में पढ़ ले, दिसंबर में FMGE एग्जाम में पढ़ ले। फालतू की जगह पर दिमाग खराब मत करो, जल्दी से पढ़ो और पास हो जाओ। लोग तो बोलते रहते हैं, उसके बहुत सारे कारण हैं, क्योंकि लोगों को बोल बोल के अब मैं कुछ बोलना नहीं चाहता। सिर्फ इतना भगवान से प्रार्थना करता हूं, किसी बच्चे का टाइम फालतू के चैनल पे फालतू की चिकनी चुपड़ी बातें सुनने में खराब ना हो। चिकनी चुपड़ी बातें करके लोग बोल तो देते हैं, लेकिन टाइम बच्चे का खराब होता है। प्लीज प्लीज प्लीज। नेक्स्ट क्वेश्चन। A primigravida lady presents with 6 weeks amenorrhea, complaining of lower abdominal pain and mild vaginal bleeding. Urine pregnancy test is positive and SCG levels are 6,500. Ultrasound shows left adnexal mass measuring 6 by 5 centimeter with fetal cardiac activity. Her blood pressure is 80 by 60 mm of mercury. She is complaining of shoulder tip pain too and urge for defecation. Come back, just come to me. What is the most appropriate management? So what this 7-liner question, 6 to 7-liner questions is giving us. The first message, she is a primigravida lady. The second message, she is presenting with 6 weeks amenorrhea. And the complaint is lower abdominal pain and mild vaginal bleeding. 6 weeks amenorrhea, lower abdominal pain. Amenorrhea, lower abdominal pain, vaginal bleeding. So these first two lines are taking us towards ectopic pregnancy. Maybe ectopic pregnancy because most common symptom in ectopic pregnancy is lower abdominal pain. In gynecology, most common symptom in PID is lower abdominal pain. But in PID, urine pregnancy test is negative, while in ectopic pregnancy, urine pregnancy test is positive. So it looks like a ectopic. Let's read the question further. Test is positive and HCG levels are 6,500. Oh my God, 6,500. Ultrasound shows left adnexal mass with fetal cardiac activity. Oh my God. Fetal cardiac activity is present in adnexa, means in tubo-ovarian region. So it has confirmed that this is a case of ectopic. Her blood pressure is 80 by 60, means blood pressure is very low. BP has fallen. She is complaining of shoulder tip pain. If BP has fallen, means it is a case of ruptured ectopic pregnancy because the tube has ruptured, which has led to massive bleeding inside, which has resulted in decreased blood pressure. तो BP इतना कम इसलिए हुआ बेटा क्योंकि ट्यूब फट गया और ट्यूब फट के अंदर बहुत ज़्यादा bleeding हुआ. And because of this massive hemoperitoneum, massive blood is collected in peritoneal cavity, which is irritating diaphragm. And because of irritation of diaphragm, pain is referred to shoulder. And because of this massive hemoperitoneum, this blood has gone to pouch of Douglas, which is the most dependent part of peritoneal cavity. And this pooling of blood in pouch of Douglas is resulting in urge for defecation. So urge for defecation due to pooling of blood in pouch of Douglas, shoulder pain because of massive hemoperitoneum, irritating diaphragm. So this is very well a case of ruptured ectopic pregnancy and she is hemodynamically unstable, BP is 80 by 60. Now what is the last line of this clinical question? Last line of this clinical question is, what is the most appropriate management for her? What is the most appropriate management for her? 3 doses of methotrexate injection. Methotrexate injection means medical management for ectopic pregnancy. Medical management for ectopic pregnancy is given. It is given if beta HCG levels are 1000 to 5000. Fine. But in between I could not talk to you much because I wanted to give you more and more information. Now let's connect with each other. Medical management, methotrexate injection is given if HCG levels are between 1000 to 5000 international units per liter. Very, very important MCQ zone for our exam. So HCG levels 1000 to 5000 if ectopic mass size is less than 4 centimeter and if cardiac activity is absent. Here HCG levels are 6500, mass size is 6 by 5 centimeter, cardiac activity is present. So methotrexate is out of question. Laparoscopy is out of question because she is hemodynamically unstable. Laparoscopy cannot be done. Laparotomy will be done with unilateral salpingectomy. Laparotomy will be done with unilateral salpingectomy because she is hemodynamically unstable. Although in primigravida lady, we try to do linear salpingostomy. But linear salpingostomy is done if she is hemodynamically stable, means if it was unruptured ectopic. How do we manage ectopic? Expectant management if HCG levels less than 1000. Medical management if 1000 to 5000. Surgical management if more than 5000. So here surgical would be done. In surgery, preferred choice is laparoscopy, but laparoscopy is done if she is hemodynamically stable. If she is hemodynamically unstable, laparotomy is done. In this question, she is hemodynamically unstable, so laparotomy will be done. In this question only, if her blood pressure was normal, if she was hemodynamically stable, then answer would have been laparoscopy with linear salpingostomy because she is a primigravida lady. This is the ultrasound image of ectopic pregnancy. As you can see, this is uterus and this is the endometrium. And this is the adnexa. And in this adnexa, you can see this is the gestational sac, this is the yolk sac. So all this is present in tubo-ovarian region. This is the laparoscopy image of ectopic pregnancy. This tube is normal, but you can see this fallopian tube is swollen with ectopic pregnancy. This is the case of ruptured ectopic pregnancy. As you can see here, this is the posterior wall of cervix and uterus, and this is the free fluid in peritoneal cavity. And ample amount of free fluid in peritoneal cavity is seen in ruptured ectopic. This is the laparoscopy image of ruptured ectopic where you can see this is the blood. So blood in peritoneal cavity is seen in ruptured ectopic pregnancy. Next question. A primigravida lady presents in labor. Her pelvis is android. Fetal position was right occipito-posterior initially, which became right occipito-transverse and is persisting for last 1.5 hours. What is the next step? So what is this condition? Tell me. It is a chocolate question. What is this condition? Please. This is a chocolate question. Anyone who answers first will get the bigger one. Anyone who answers first will get the bigger chocolate. Please tell me. What is this condition? First of all, what we are dealing with this in this question. A primigravida lady, what has happened to her? Occipito-transverse for last 1.5 hours. Occipito-transverse for last 1.5 hours. What is this condition? Can anybody? What is the next step? Answer is D, Caesarean section. Wonderful. Answer is D, Caesarean. Can you write what is this condition? What is the name of condition? Can you write what is the name of this condition? I am waiting. Can you write what is the name of this condition? Where the occiput is stuck transversely for last 1.5 hours and the pelvis is android. Pelvis is android. Deep transverse arrest. Ramesh, you are the first one, and Ramesh, you deserve this chocolate. First one, bigger chocolate, rest of all, small chocolate. So this is no, this is not obstructed labor. This Rabia, Umesh, This is the case of Anupriya. This is the case of deep transverse arrest. Wonderful. Wonderful. Deep transverse arrest. So let's quickly revise. Deep transverse arrest, if occiput is stuck transversely. If occiput is stuck transversely here, just give me one moment. Occiput is stuck transversely for more than 1 hour, that is called deep transverse arrest. Let's quickly go through the images here. This image question was asked in our exam. This was asked in our exam in last session. And the question was about gynecoid pelvis. This pelvis was given. So how we identify these pelvis? If the inlet is round, this is gynecoid pelvis. If transverse diameter is much larger, like this. If transverse diameter is much larger, this is called platypaloid pelvis. If anteroposterior diameter is much larger, this is called anthropoid pelvis. If fore pelvis, anterior half of pelvis is narrow than posterior half, this is called android pelvis. So deep transverse arrest, if occiput has moved, most common occipito-posterior position is right occipito-posterior. If occiput has moved 1/8 and is stuck here transversely for more than 1 hour, this condition is called deep transverse arrest. Management of deep transverse arrest in android pelvis is only Caesarean section. In any other pelvis, if deep transverse arrest occurs, vacuum may be tried because vacuum promotes autorotation. But the best management would be Caesarean section. Quickly, let's go through these image questions. Chocolate question. Come on, quickly. We'll solve these chocolate questions quickly. Identify the pelvis. Give me the answer quickly. Give me the answer quickly. Chocolate question. What is this condition? Which pelvis? Quickly. I'm waiting. What is this pelvis? Nigle. Wonderful. One ella is absent, only one ella is present. So if this image question is given, Nigle. Identify this condition. Which pelvis? Chocolate question. Identify the pelvis. Quickly, quickly revise with me. Quickly. So this session is not only about 25 clinical questions, but revision of very important single liners quickly. And we will finish this session just after 40 or 45 minutes. So let's move quickly. Identify the condition. This is Robert's pelvis. You can see both ella of sacrum are absent. This is bean-shaped pelvis. It is seen in severe rickets in children. This is triradiate pelvis seen in osteomalacia in adults. Fine. Let's move to another question. A pregnant lady presents at 37 weeks with history of Caesarean section due to footling breach in previous pregnancy. So she is presenting at 37 weeks of pregnancy. She gives history of Caesarean in last pregnancy. And Caesarean in last pregnancy was done due to footling breach. What was the reason for Caesarean in last pregnancy? It was footling breach. She is with cephalic presentation right now. In this pregnancy, it is cephalic presentation and position is left occipito-transverse. We know normal and most common presentation cephalic, single liner question. We know most common position is left occipito-transverse, again an important single liner question which I try to incorporate in this clinical vignette based question. Placenta is fundoposterior. Another important single liner question, most common location of placenta is fundoposterior. What is the most appropriate management for her? So right now she is normal beta. Examiner has given you the Caesarean section history and the reason for previous Caesarean was footling breach. Right now she is cephalic, she is not in breach. Right now position is also normal. Fundoposterior is the location of placenta. Now what should be done? What is the most appropriate management for her? Lower segment Caesarean section is the only management. Why lower segment Caesarean section is not the only management? Because vaginal delivery may be tried if there is history of previous 2 Caesarean section. And in this question, there is history of only one previous cesarean section, and this pregnancy is normal. So that's not the only management. We can try vaginal delivery. Classical cesarean section is the only management. No way. Upper segment cesarean section is done only for few conditions like dense adhesions in lower segment, placenta completely covering internal os, or if it is a case of repaired vesicovaginal fistula, morbidly adhered placenta, or if you are doing a post-mortem in a dead lady. Out of question. Vaginal delivery may be tried, yes. Internal podalic version is done in twin pregnancy when second twin is in transverse lie. So answer to this question is vaginal delivery may be tried. Another important message from my side, increase your specific gravity. अपने आप को मजबूत करो, ज्यादा फालतू के चैनल वो पे जाके लोगों की बातें मत सुनो, काम की बातों में दिमाग लगाओ. Just focus on 30th July FMG exam. Don't focus on various channels which are just draining and picking up your brain. FMG exam will happen on 30th July. We are preparing for FMG exam. What to do? RRS formula, read, repeat, speak out. Read, repeat, speak out. पढ़ो, दोबारा पढ़ो, मुंह से बोलो अगर याद नहीं हो रहा, पढ़ो, दोबारा पढ़ो और मुंह से बोल के पढ़ो अगर याद नहीं हो रहा. खुद से, दूसरे की किसी की नहीं सुनना. जवाब खुद से मिलेगा, अंदर से मिलेगा, बाहर से नहीं मिलेगा. And develop a habit of connecting the dots. If you connect the dots consistently, देखो एक पहिया भी चलता है ना, एक पहिए से दूसरा पहिया, दूसरे से तीसरा पहिया, तो ये सब डॉट्स जब हम कनेक्ट कर लेंगे ना तो हमारी गाड़ी बहुत अच्छे से चलेगी. Try to connect the dots and be consistent in RRS formula, reading, repeating and speaking out. Be consistent, do it daily. रोज पढ़ना है, दोबारा पढ़ना है, बोल के पढ़ना है, खुद ही पढ़ना है, अपने आप से पढ़ना है, किसी और का नहीं सुनना है. केवल काम की बात सुननी है, जो पढ़ाई की बात है. आज के इस सेशन में मैं बहुत ज़्यादा मोटिवेशन वाली बातें नहीं कर रहा, क्योंकि मुझे ये मालूम है कि मेरे बच्चों को ओबीजी 30 जुलाई को कुछ और दे सकती है. इसलिए ओबीजी की बातें ज़्यादा कर रहा हूँ और बहुत ध्यान से सुन लेना. मेरी बात याद रखोगे 30 जुलाई की शाम को. A 26-year-old girl presents with infrequent cycle. Her age is 26 years. Her complaint is infrequent cycle. ओके जी, बच्ची की बिटिया की एज कितनी है? 26 साल. और बिटिया की कंप्लेंट क्या है? Infrequent cycle. Infrequent cycle if she is having cycle after 38 days. What is a frequent cycle? जरा सिंगल लाइनर रिवाइज कर लो. If she has periods before 24 days. She has suddenly developed mustaches, beard and hoarseness of voice. Her breasts are not clearly visible now. So what word is mentioned in the question? Suddenly. And she has developed these androgenic features like acne, mustaches, beard and hoarseness of voice. Her breasts are not clearly visible now. Serum androgen levels are 450. Which of the following is most likely? Who answers first? Oh my God, many students have answered. Wonderful. So, wonderful. Vikrant, Sharik, Sabatina, Prachi, Vibrant, VK, Motilal, ऐश्वर्या, रितेश, मुझे सबके नाम याद है और सबकी चॉकलेट मेरे पास ड्यू है. इसी सेशन में मैंने ऑलरेडी अपना फ़ोन नंबर दे दिया. यू कैन नोट माय फ़ोन नंबर वंस अगेन. आई प्रॉमिस यू, और मैं अपना वादा निभाऊंगा. सबकी चॉकलेट मेरे पास रखी है आपकी अमानत के तौर पर. आंसर टू दिस क्वेश्चन इज डी, दैट इज एंड्रोजन सीक्रेटिंग ovarian tumor. Because of which word, beta? Only one word changes the diagnosis suddenly. PCOS is a slow process. In PCOS also, complaint is infrequent cycle. Complaint is acne, mustaches, beard. But in PCOS, hoarseness of voice is not present. In PCOS breasts are visible. Hoarseness of voice, atrophy of breath, they are virilizing features. And we know very well, if any virilizing feature is mentioned in question, or if the word suddenly is mentioned in question, answer is not polycystic ovarian syndrome. If word virilizing feature, any virilizing feature is mentioned in the question, or if the word suddenly is mentioned in the question, answer is not polycystic ovarian syndrome. Answer is a condition which is secreting androgens in excessive amount and suddenly. So answer to this question is androgen secreting ovarian tumor. If word suddenly was not mentioned, if hoarseness of voice was not mentioned, if breasts are not visible was not mentioned, then answer to this question would have been polycystic ovarian syndrome. Quickly, what is this? This is acanthosis nigricans. Brownish black pigmentation over neck, axilla, elbow, feature of insulin resistance, which is seen in polycystic ovarian syndrome. This is acne. Again, this image may be clubbed with any PCOS question, feature of PCOS. This is hirsutism. Hirsutism is development of male pattern sexual hair, and most common cause of hirsutism PCOS. चलो, ये सारे सिंगल लाइनर कर लिए. ये इमेज क्वेश्चन अगर आ गया, कोई गलती नहीं करेगा. नोबडी विल कमिट अ मिस्टेक. अगला क्वेश्चन सॉल्व करते हैं. फाइन. अ 9 वीक्स मल्टीग्रेविडा, 9 वीक्स पे आई है. अ 9 वीक्स मल्टीग्रेविडा प्रेजेंट्स विद इरेगुलर ब्लीडिंग पर वजाइनम विद पैसेज ऑफ ग्रेप लाइक वेसिकल. ओके जी, 9 वीक्स की प्रेगनेंसी है. Complaint is irregular bleeding per vaginum with passage of grape-like vesicle. In our ops kahini beta, the moment you read the word grape-like vesicles, what comes to your mind? If the word grape-like vesicles you see with irregular bleeding, we immediately think it is a case of vesicular mole. And the second clue is hyperemesis gravidarum. What is the reason for hyperemesis? Excessive vomiting, excessive nausea, vomiting. Nausea and vomiting in pregnancy are due to HCG, human chorionic gonadotrophin. Hyperemesis is a feature of molar pregnancy, which is another supporting evidence for molar pregnancy, because molar pregnancy is abnormal proliferation and degeneration of chorionic tissue, and HCG is secreted from syncytial trophoblast. Since there is abnormal and excessive proliferation of syncytial trophoblast, there is excessive secretion of human chorionic gonadotrophin, which is resulting in hyperemesis gravidarum. And features of thyrotoxicosis, we know which subunit of HCG is specific to pregnancy. Important single liner, beta subunit. Alpha subunit of HCG is similar to FSH, LH, TSH. Since alpha subunit of HCG is similar to TSH, many patients with molar pregnancy may have features of thyrotoxicosis. And what are theca lutein cysts? They are cysts of corpus luteum. Why theca lutein cysts develop in molar pregnancy? Because pregnant corpus luteum is supported by HCG. Since HCG is excessive in molar pregnancy, there is excessive support to corpus luteum, which results in enlarged corpus luteum. So theca lutein cysts, grape-like vesicles, most common symptom of molar pregnancy, irregular bleeding PV, alpha subunit of HCG similar to TSH. So all these clinical keywords are taking the question towards molar pregnancy. And which molar pregnancy? Complete mole, which is also called hydatidifform mole, which is also called vesicular mole, because passage of grape-like vesicles is seen in which mole? Vesicular mole. Now, the last line of the question, who will answer the question? The most appropriate management for her. D, wonderful yaar. It's not A, Nitesh, it's not B, Rajesh, Abdullah, no. Why beta, why? Why you want to do cystectomy? No, beta, ovarian cyst is not a ovarian pathology. Ovarian cyst is due to excessive HCG, which is supporting corpus luteum. If you take out the molar tissue, HCG levels will fall and ovarian cyst will disappear. It is not a pathology of ovary. Ovarian cysts are due to excessive HCG, which is secreted by molar tissue. If you take out the molar tissue, HCG levels will fall, support to corpus luteum will fall, and theca lutein cysts will regress. So we have to focus on taking out the molar tissue. What is the management of molar pregnancy? Which keyword is mentioned in the question multigravida? Management of molar pregnancy in multigravida is total abdominal hysterectomy, because molar pregnancy right now it is benign but it carries malignant potential. So if future childbearing is not required, we favor total abdominal hysterectomy. If the word primigravida was mentioned in the question, answer would have been, now you tell me the chocolate question. If the word primigravida was mentioned in this question, answer would have been, quickly, question in waiting on 30th July. If the word primigravida was mentioned in the question, answer would have been, quickly. If the word primigravida was mentioned in the question, wonderful, Rabia, Aishwarya, wonderful. Everyone is clear. So if it was primigravida, suction evacuation. If she is multi, total abdominal hysterectomy. Let's quickly revise few images, very important for our exam. So this session I'm trying to contribute a lot from my side. So this is a gross specimen of vesicular mole or hydatidiform mole. As you can see, numerous grape-like vesicles. So this is a gross specimen of vesicular mole. Vesicular mole is also called hydatidiform mole. It is also called complete mole. Another very important question for our exam, this ultrasound image is given. This is ultrasound of uterus. And you can see numerous black vesicles. So this is snowstorm appearance. So ultrasound uterus with snowstorm appearance, diagnosis is complete mole or vesicular mole or hydatidiform. This is partial mole ultrasound image. Fetus is seen in partial mole, and this is the abnormally proliferated placenta. So abnormally proliferated placenta with fetus, partial mole. Snowstorm appearance of uterus, complete mole. Gross specimen of hydatidiform mole. How do you identify? You can see these vesicles. This specimen is choriocarcinoma. If in any question examiner gives you a clinical keyword, she is presenting with irregular bleeding per vaginum. Most common symptom of choriocarcinoma is also irregular bleeding per vaginum. So if irregular bleeding per vaginum, one word mentioned, second word, reddish blue mass. Choriocarcinoma appears a reddish blue mass. So what second word you may find in the question? Reddish blue mass. Reddish blue mass, irregular bleeding per vaginum, HCG levels are not falling. In fact, they have started rising again. These clinical keywords are taking the question towards choriocarcinoma. And this is the X-ray chest appearance in choriocarcinoma. Who will answer this question? A chocolate question. Who will answer this question? If this X-ray chest appearance is given with a reddish blue mass, history of irregular bleeding per vaginum, HCG levels are static or in fact they have started rising again. Wonderful, very good. Mukesh, Sanjay, this is the case of cannonball appearance. So this is metastasis in choriocarcinoma. Wonderful, very nice. Chalo ji. Next question. A 22-year-old virgin girl presents with shortened and light menstrual bleeding for last 1 year. Shortened bleeding, what is the shortened bleeding? According to new nomenclature, shortened bleeding if duration of bleeding is less than 2 days. What is the light menstrual bleeding? According to new nomenclature, we have discussed in detail in our classes. Light menstrual bleeding if amount of blood loss in single episode of menstruation is less than 20 ml. And she is presenting with this complaint for last 1 year. She is complaining of low-grade evening rise fever, anorexia and weight loss. So low-grade evening rise fever, anorexia, weight loss, these clinical keywords are taking these two lines towards tuberculosis, which is very common in India. And tuberculosis is a very important topic for our exam because we are living in India and we are giving Indian exam. Ultrasonography shows bilateral adnexal mass. Which of the following is most likely? Now, bilateral adnexal mass again is a feature of genital tuberculosis. Which of the following is most likely? So, answer has to be tuberculosis. Answer has to be tuberculosis. Why it is not endometriosis? What keywords are missing? Dyspareunia not mentioned. Dysmenorrhea not mentioned. Progressive dysmenorrhea, progressive dyspareunia, nodular feel or cobblestone feel on pervaginal ultrasound, or ultrasound shows ovarian cyst which gives ground glass appearance, nothing mentioned. Endometriosis ruled out. Ovarian functional cyst. If it is a case of ovarian functional cyst, she will present with infrequent cycle. The old name was oligomenorrhea, new name is infrequent cycle. But here the complaint is shortened bleeding and light menstrual bleeding. Functional cysts are gone. Genital tuberculosis, all the clinical keywords, low-grade evening rice fever, anorexia, weight loss, systemic symptoms of tuberculosis, and ultrasound shows bilateral adnexal mass. A virgin girl presenting with bilateral adnexal mass, what is most likely diagnosis? Genital TB. So answer is genital TB. Why it is not theca lutein cyst? Theca lutein cysts are due to excessive HCG, which are seen in molar pregnancy, multifetal pregnancy. She is not a pregnant lady. Her complaint is shortened menstrual bleeding and light menstrual bleeding. She is not pregnant. Theca lutein cysts are seen due to HCG, and HCG is seen in a pregnant lady. So answer is genital TB. Very simple. Let's quickly go through these HSG images quickly. Let's revise. Who will answer this image? What is this condition? What is this? If this hystosalpingography image is given to you, give me the answer. What is the appearance? Name of the HSG appearance. This is late pipe appearance or pipe stem appearance seen in genital TB. Second question. What is this HSG appearance? Tobacco pouch appearance. This is tobacco pouch appearance. What is this appearance? Beaded appearance. Beaded appearance. So beaded appearance in HSG, tobacco pouch appearance in HSG, late pipe appearance or pipe stem appearance in HSG, they are all seen in genital TB. And what is the name of this appearance? This is golf stick appearance. So golf stick appearance on HSG, or late pipe or pipe stem appearance on HSG, or tobacco pouch appearance on HSG, they are all seen in genital TB. Let us go through these ultrasound images quickly. This ultrasound image is bead on string sign seen in PID. This is ultrasound image waist sign seen in PID. This is cogwheel sign seen in PID. This is ultrasound image of hydrosalping. Linear tubular blackish structure, blackish because it contains fluid which appear black in ultrasound. Next question. A lady presents with continuous dribbling of urine. She is presenting with continuous dribbling of urine through vagina. She is feeling desire to micturate on her own as well. So tell me what should be the answer. Continuous dribbling of urine through vagina, and she is feeling desire to micturate on her own as well. बार बार कंटिन्यूअसली वजाइना से ब्लड आ रहा है. चॉकलेट क्वेश्चन क्विकली. वजाइना से ब्लड आ रहा है और साथ में उसकी भी इच्छा होती है कि सूसू जाना है. She feels a desire to micturate on her own also. Methylene blue 3 swab test was done, which shows wetting of swabs, but they don't stain with color. What is the most likely diagnosis? बताओ जल्दी से क्या हो रहा है ये? What is this condition? This condition is, what is the answer? Wonderful, wonderful. Shubham Thakur, correct answer. Ruchi, correct answer. Ashish, correct answer. Uretrovaginal fistula. Uretro, VK. Abhi, no, it's not vesicovaginal, beta. How do you differentiate? In vesicovaginal fistula, she will not feel a desire to micturate on her own. Uretrovaginal fistula, dribbling of urine through vagina, that is continuous, and she feels a desire. Vesicovaginal fistula, she does not feel a desire to micturate on her own. Urethrovaginal fistula, dribbling of urine through vagina only at the time of micturition. And vesicouterine fistula, hematuria at the time of menstruation, which is called menouria. Menouria is seen in two conditions, vesicouterine fistula and endometriosis of urinary bladder. So answer to this question is uretrovaginal fistula. Let's quickly go through these image questions. This image question was asked in our exam 3 sessions back. They gave this image question, identify the pathology. How do you identify? You can see that there is a defect here. This circle is put here or arrow is put here, and what you have to see that there is a communication between urinary bladder and vagina. If there is a communication between urinary bladder and vagina, what is this condition? Vesico-vaginal fistula. So this was our exam question. Now, various other image questions may be asked. Number 1 is vesico-uterine fistula. You can see this is the abnormal connection, this is the uterus, and this is urinary bladder. So abnormal connection between uterus and bladder, vesico-uterine fistula. Number 2 is vesico-vaginal fistula, this one. Number 3 is urethrovaginal fistula, and number 4 is recto-vaginal fistula. This is the image of methylene blue 3 swab tag. Fine. Next question. Early deceleration is starts after uterine contraction, begins and ends after uterine contraction, and this is late deceleration. So this is not the answer. Early deceleration starts with uterine contraction and ends with uterine contraction. So early deceleration starts with contraction and ends with contraction. Late deceleration starts after uterine contraction begins and ends after uterine contraction and starts before uterine contraction begins and before, that is not at all. NST plus AFI is modified biophysical profile. So answer to this question is B. Early deceleration. Let's go through the images. This is the early deceleration, look here. This is the uterine contraction peak, look here. This is the fetal heart rate deceleration. This heart rate is decreasing here. You can see this fetal heart rate tracing. There is dip in fetal heart rate, and you can see this dip coincides with peak of uterine contraction. This is the uterine contraction, and you can see decrease in fetal heart rate is coinciding with peak of uterine contraction. This is called early deceleration. It is physiological. It is seen in head compression. Look at the late deceleration. This is the dip in fetal heart rate. And this dip in fetal heart rate starts after the peak of uterine contraction and ends after the contraction is over. So this is late deceleration, which is seen in uteroplacental insufficiency. This is pathological. This is variable deceleration, not at all related with uterine contraction. It is seen in umbilical cord compression. This is the image of cardiotocography, CTG. It is NST at the time of labor, where we put 2 electrodes. Fine. And if this image question is given in our exam, identify the condition. This is non-stress test, where we are monitoring acceleration in fetal heart rate with uterine contraction. Chalo. Get rid of अच्छा बनना syndrome and just beware of flutterers and backbiters. थोड़ा सा बस एक चीज ध्यान रखना बेटा, what we have to remember, कई बार ना हमें लोग बड़ा चढ़ाते रहते हैं, यार तुझे तो सारा याद है, you remember everything, तुझे सब याद हो जाता है. और इन चिकनी चुपड़ी बातों में, किसी की चिकनी चुपड़ी सूरत पे, चिकनी चुपड़ी बातों में लोगों की ना बड़ी चापलूसी की, चमचागिरी की आदत होती है. तो उनमें फंसना नहीं है, हमें अपनी पढ़ाई पे फोकस करना है केवल. लॉट ऑफ एनालिसिस लीड्स टू पैरालिसिस. नेक्स्ट क्वेश्चन. टाइम ज़्यादा लगा आज बेटा, थोड़ा सा, जस्ट 15-20 more minutes. Which of the following is most appropriate management for carcinoma cervix stage 1B1 in a young nulliparous lady willing to conceive? So carcinoma cervix 1B1. What is 1B1? 1A1 less than 3 centimeter invasion, A2 3 to 4, B1 5 or more than 5 millimeter but less than 2 centimeter. And we know if size of cervical cancer is less than 2 centimeter and if she is a young nulliparous lady willing to conceive, means we should try to preserve her uterus. So if size of cervical cancer is less than 2 centimeter, vaginal trachelectomy can be done. Trachelectomy is removal of cervix and parametrium. So here no need for a hysterectomy. So answer is vaginal trachelectomy. Trachelectomy is removal, as you can see in this box. We remove only cervix and parametrium. This is trachelectomy. A lady presented in labor room with uncomplicated pregnancy. Placenta was fundoposterior and amniotic fluid was adequate. Obstetrician started pulling the cord without seeing signs of separation of placenta, as he was in hurry. After few minutes, there was mild bleeding per vaginum, following which a reddish mass was expelled out of vagina. The patient complained of severe pain and developed hypotension, tachycardia, and went into shock. What is most likely? So this lady presented with uncomplicated pregnancy. Her pregnancy was uncomplicated throughout. Antenatal period was okay. Placenta was fundoposterior normal. Amniotic fluid was adequate. Everything was normal. Obstetrician डिलीवरी कर रहा था, started pulling the cord, और उसने ये नहीं देखा that placenta has separated, and otherwise controlled cord traction is given. So what has happened? उसने cord खींच दिया. After few minutes bleeding शुरू हो गया और एक reddish mass बाहर आ गया. Because obstetrician did not do controlled cord traction, without seeing the signs of placental separation, uterus has turned inside out. This is called uterine inversion. And the most common cause of uterine inversion is mismanaged third stage of labor. तो भैया कॉर्ड ऐसे ही खींच दोगे, यूट्रस बाहर आ जाएगा, which is called uterine inversion. The patient complained of severe pain. What is the cause of pain? Neurogenic shock, and developed hypotension, tachycardia. Shock में चली गई. What is most likely? Morbidly adhered placenta. अगर ये morbidly adhered placenta होता, अगर ये morbidly adhered placenta होता, तो हमको morbidly adhered placenta का कोई क्लू, एक्रीटा, इनक्रीटा, परक्रीटा, अल्ट्रासाउंड की कोई फाइंडिंग हमें क्वेश्चन में मिली होती. Nothing is mentioned here. Amniotic fluid embolism. In this kind of question, if you get one clue, breathlessness, अगर क्वेश्चन में breathlessness मिल जाए, then answer will be amniotic fluid embolism. Because of embolism, there is no word breathlessness here. And in amniotic fluid embolism, it is not like this that there is expulsion of a reddish mass out of vagina. No way. Postpartum hemorrhage में clinical keyword क्या मिलेगा? Excessive blood loss. क्या मिलेगा? Excessive blood loss. Nowhere in the question it is mentioned that there is excessive blood loss out of vagina after delivery of baby. The clinical clue mentioned is something is expelled out of vagina, a reddish mass, means a uterus turned inside out. So most likely diagnosis is uterine inversion. In this kind of question, if excessive blood loss return, nothing else mentioned, PPH होएगा. In this kind of question where there is shock after delivery, if you get the clinical keyword breathlessness, answer is amniotic fluid embolism. And if something is coming out of vagina, properly cord was not taken out, the answer is uterine inversion. This is the image of controlled cord traction, which is called modified Brent-Andrews technique. This is how normally controlled cord traction is done. If it is not done, uterus turns inside out. These are the images of uterine inversion, various degrees. First degree, you can see dimpling at fundus. Second degree of inversion, uterus turned inside out up to internal os. Third degree up to external os or below. And fourth degree, whole uterus turns inside out. And this is Johnson's method for correction of uterine inversion. What is Johnson's method? Manual reposition of uterus. This is the umbilical cord cutting scissor. This is the cord clamp. And this is the modified Ritgen maneuver, which is recommended by WHO to manage second stage of labor. Whenever anything breaks, it liberates energy. जब भी कोई चीज टूटती है ना बेटा, उससे एनर्जी निकलती है. If your heart or dream is broken due to any reason, you are becoming nucleus of energy. जब भी तुम्हारा दिल टूटे या तुम्हारा सपना टूटे, समझ लेना ऊपर वाले ने तुमको चुन लिया है किसी एनर्जी का केंद्र बनने के लिए. इसके बाद ये तुम्हारे ऊपर है कि इस एनर्जी का क्या करोगे। इट्स अप टू अस वेदर वी वांट टू मेक बॉम्ब और बल्ब आउट ऑफ दिस एनर्जी, एंड वी ऑल आर वेरी इंटेलिजेंट गाइज, वी आर गोइंग टू क्रिएट ए बल्ब आउट ऑफ दिस एनर्जी। अगर कुछ भी टूटता है ना, एनर्जी निकलती है। हमारा दिल या सपना टूटेगा, एक एनर्जी निकलेगी और वो एनर्जी एक बल्ब बनाएगी, एक बॉम्ब नहीं बनाएगी। नेक्स्ट क्वेश्चन बेटा, क्वेश्चन बड़े बड़े हैं, टाइम लग रहा है, लेकिन गोल है, क्योंकि सब जानते हो फालतू के डरे हुए हैं, बड़ी टेंशन हो रही है। इस सेशन को देख लेना, ओबीजी ऐसे ऐसे निकल जाएगी, बिल्कुल ऐसे ऐसे निकल जाएगी। अ प्राइमी ग्रेविडा प्रेजेंट्स टू द एंटीनेटल क्लिनिक एट 14 वीक्स ऑफ gestation. So एक प्राइमी ग्रेविडा आई 14 वीक्स प्रेगनेंसी पे। शी कंप्लेन्स ऑफ हाइपरइमेसिस ग्रेविडेरम। ओके जी, क्यों हो रहा है भाई? एक्सेसिव नोशिया, वॉमिटिंग। ऑन एग्जामिनेशन फंडल हाइट इज मिडवे बिटवीन प्यूबिक सिम्फाइसिस एंड अम्बिलिकस। फंडल हाइट मिडवे बिटवीन प्यूबिक सिम्फाइसिस एंड अम्बिलिकस, 16 वीक्स प्रेगनेंसी। Midway between pubic symphysis and umbilicus, 16 weeks pregnancy. But she is saying that she is 14 weeks pregnant. The lambda sign is seen on ultrasonography. Oh my God. Lambda sign is seen in twin pregnancy. Which twin pregnancy? Dichorionic. Dichorionic lambda sign, monochorionic T sign. Dichorionic lambda sign. Lambda sign is also called twin peak sign. Super duper important for our exam. And why fundal height is more than period of amenorrhea? Because दो बच्चे हैं अंदर, twin pregnancy. She says 14 weeks, but fundal height is 16 weeks. तो dichorionic twins. What are these twins? Lambda sign है तो कौन से twin है? Dichorionic twins. Dichorionic. Lambda sign में कौन से twins मिलेंगे? Dichorionic. जल्दी से इमेज देख लो, सुपर डुपर इंपॉर्टेंट फॉर अवर एग्जाम। बताओ, चलो मैं ही बता देता हूँ जल्दी से, क्योंकि टाइम भी लग रहा है ना, अभी चॉकलेट बाद में खा लेंगे। दिस इज ट्विन पीक साइन और लैम्डा साइन, वेरी इंपॉर्टेंट फॉर अवर एग्जाम। लैम्डा कैसे बना बेटा? ये बन गया, दिस इज लैम्डा। लैम्डा साइन और ट्विन पीक साइन किस कंडीशन में? डाइकोरियोनिक प्रेगनेंसी। ये टी बन गया बेटा, कैसे बना देखो, दिस इज टी साइन। T sign on ultrasound is seen in monochorionic pregnancy. Very important image questions for our exam. These are parapagous twins. Most common variety of conjoined twins are parapagous. Second most common variety of conjoined twins are thoracopagous. This is the image of twin-twin transfusion syndrome where one twin is donor and other is recipient. चलो, You are sitting alone at your home. बहुत सारे स्टूडेंट्स बोलते हैं सर हम ऑनलाइन में पढ़ रहे हैं, तो ऑनलाइन में लगता क्या है कि हम घर पे अकेले बैठे हुए हैं। इफ यू आर फीलिंग अलोन, ऐसा लगता है मैं अकेला हूं, इफ यू फील अलोन, योर कंसंट्रेशन, योर फोकस इंक्रीजेस मल्टीफोल्ड. Whether they are offline students, whether they are online students, all the students are now revising at their home. They may be alone. If you are alone, believe me and take it from me, your focus and increases multifold. Your concentration increases multifold. क्योंकि कई बार हम बहुत सारे लोगों के साथ बैठते हैं ना, लोग मोटिवेट कम करते हैं, डिमोटिवेट ज़्यादा करते हैं। बहुत सारे चैनल्स पे, बहुत सारे प्लेटफॉर्म पे रोज स्टूडेंट्स को आधा आधा घंटा घेरने की क्या जरूरत है, मेरी ये समझ में नहीं आता। एक ही बात को बार बार बोलने की क्या जरूरत है, मेरी ये समझ में नहीं आता। क्या जरूरत है बार बार करने की? जो बार बार करना है वो स्टूडेंट को खुद करना है। RRS फार्मूला, रीड, रिपीट, स्पीक आउट। बच्चे को खुद पढ़ना है, बच्चे को खुद दोबारा पढ़ना है, बच्चे को खुद बोल के पढ़ना है। किसी का सुनना नहीं है, अपना सुनना है। अपने दिल की सुनो। 30 जुलाई फोकस। चिकनी चुपड़ी बातों में मत बह जाओ। लोग अपना काम कर जाएंगे जो वो चाहते हैं, तुम नहीं कर पाओगे। तुम अपने को देखो, अपने अंदर झांको। RRS, रीड, रिपीट, स्पीड आउट। खुद का, किसी दूसरे का नहीं। फाइन। अकेले आए थे, अकेले जाएंगे। एक बात याद रखना, अकेले आए थे, अकेले जाएंगे, लेकिन इतिहास पढ़कर नहीं, इतिहास लिख कर जाएंगे। घर में बैठे हैं, अकेले रिवाइज कर रहे हैं, इतिहास रचेंगे, इतिहास लिखेंगे अकेले। दूसरों का इतिहास नहीं पढ़ेंगे। हमें किसी चंद्रगुप्त मौर्य को नहीं पढ़ना। वो आज की तारीख में भी अगर कोई चंद्रगुप्त मौर्य बनने की कोशिश करता है बार बार बच्चों का टाइम खराब करके, तो हमें वो भी चंद्रगुप्त मौर्य नहीं बनना। हमें अपने आप को मजबूत करना है, अपना इतिहास खुद लिखना है, काम की बात पढ़नी है, सब्जेक्ट पढ़ना है। 30 जुलाई वैसे ही डरे हुए हैं यार, ये कौन सा एग्जाम आ रहा है, ये कौन सा आ रहा है। पढ़ लो पढ़ लो पढ़ लो पढ़ लो, किसी और की मत सुनो, अपना पढ़ लो। A lady presents with history of 4 months pregnancy. A lady presents with history of 4 months pregnancy with bleeding per vagina and history of expulsion of pieces. 4 महीने की उसको प्रेगनेंसी है, वेजाइना से ब्लड आ रहा है और बोल रही है डॉक्टर साहब टुकड़े भी गए हैं। शी इज सेइंग 4 महीने की प्रेगनेंसी है मुझे, वेजाइना से ब्लड आ रहा है और डॉक्टर साहब कुछ टुकड़े भी गए हैं, एक्सपल्शन ऑफ पीसेस। पर एब्डोमिनल एग्जामिनेशन शोज फंडल हाइट लेस देन 4 मंथ। वो बोल रही है 4 महीने की प्रेगनेंसी है, लेकिन हमने जब फंडल हाइट चेक किया हमको 4 महीने से कम मिला। क्वेश्चन पढ़ के ही समझ में आ रहा है, वी आर एबल टू कंक्लूड बिकॉज शी हैज पास सम पीसेस, कुछ टुकड़े भी निकल गए, तो फंडल हाइट कमी है, क्योंकि सामान कुछ तो बाहर चला गया, तो फंडल हाइट कमी मिलेगी जितना वो बताएगी उससे। कोई रॉकेट साइंस तो नहीं है। इंटरनल ऑस इज ओपन, तभी तो टुकड़े निकले। इंटरनल ऑस इज ओपन, दिस इज हाउ शी कुड पास द पीसेस। पर वेजाइनल एग्जामिनेशन किया, इंटरनल ऑस ओपन मिला, व्हाट इज मोस्ट लाइकली डायग्नोसिस? थ्रेटेंड अबॉर्शन में शी विल नेवर कंप्लेन, she will never complain of expulsion of pieces. In threatened abortion, fundal height is equal to period of amenorrhea and internal os is closed. So in this question, if internal os was closed, fundal height was equal to period of amenorrhea, and if this line was not mentioned, expulsion of pieces, answer would have been threatened abortion. Inevitable abortion, she will never say that she has passed pieces. She will never say. If she is saying डॉक्टर साहब टुकड़े गए हैं, if she has passed pieces, means it is a case of expulsion of products of conception. Means she has already passed the pieces, but some pieces are retained inside. This is why this is called incomplete abortion. So this is not an inevitable abortion. This is a case of incomplete abortion. Incomplete. Inevitable भी नहीं हुआ. Why it is not missed abortion? In missed abortion, she remains asymptomatic. She does not even complain of vaginal bleeding. What to talk about expulsion of pieces? Moreover, internal os is closed in missed abortion. So answer to this question is incomplete abortion. जल्दी से थोड़ी सी image देख लेते हैं. If it is a case of incomplete abortion, you can see this image shows residual placental tissue. This is the endometrial cavity where you can see these multiple retained products of conception. Residual placental tissue. This is the case of missed abortion. Ultrasound was done. Ultrasound beam is passing through embryo and you can see a flat line. Had it been a live embryo, you could see the cardiac pulsations like this. Then it was a case of live embryo. But this is not seen, so this is a case of missed abortion. Fine. This is cervical incompetence ultrasound where we see a U-shaped cervix or U-shaped membrane which is called funneling. This is the image of McDonald stitches, cervical cerclage, which is done to treat cervical incompetence. I am covering few single liners along with management for cervical incompetence, McDonald stitches, which is called cervical cerclage. They are applied at 12 to 14 weeks pregnancy, can be applied up to 24 and taken out at 37 weeks. And most common time of abortion due to cervical incompetence is 16 to 24 weeks. These single liners are super duper important for our exam, which I am covering with all the clinical vignettes. पास हो जाओ बेटा, बस दिल से एक ही इच्छा है, जस्ट गेट रिड ऑफ फ्लैटरर्स एंड बैकबाइटर्स. 30 सेकेंड लूंगा. मैंने बोला था ना, ऐसे चमचे पड़े हैं इस दुनिया में, ऐसे फ्लैटरर्स पड़े हैं और चापलूसी एक कला है. आप ना पिघल जाते, यार तुझे सब आता है, तुझे तो सब याद है, यू रिमेंबर एवरीथिंग. ऐसा कर, अपनी वर्कबुक मुझे दे दे, अपना ये मुझे दे दे, अपना वो मुझे दे दे. इन चमचों को पहचान लो बेटा एंड जस्ट गेट रिड ऑफ दीज फ्लैटरर्स एंड बैकबाइटर्स. ये सबसे खतरनाक है. इनका काम केवल मिसअंडरस्टैंडिंग क्रिएट करके अपना उल्लू सीधा करना है। इन चमचों को पहचानो और इनको थप्पड़ मार के भगा दो। नेक्स्ट क्वेश्चन, अ लेडी प्रेजेंट्स विद हिस्ट्री ऑफ प्री-एक्लेम्सिया। So this is a pre-eclampsia question. She is presenting with history of pre-eclampsia at 26 weeks of gestation, 26 हफ्ते पे. In view of her history, you want to evaluate her risk of developing pre-eclampsia in the present pregnancy. वो बता रही है कि पहले उसको प्री-एक्लेम्सिया हुआ था, अभी वो 26 हफ्ते की प्रेगनेंसी पे आई है। अब हमको देखना है कि इस प्रेगनेंसी में भी प्री-एक्लेम्सिया हो सकता है क्या? How to see that? Which of the following results is not an indicator? बेटा इन सारे वर्ड्स को ना बहुत सीरियसली देख लेना एग्जाम में। Not, accept, all these words. So which of the following results is not an indicator for preeclampsia in ongoing pregnancy? क्या बोल रही है? जब मैं लास्ट टाइम प्रेग्नेंट थी मुझे प्री-एक्लेम्सिया था, डॉक्टर ने लिखा था, उसने हमसे कह दिया, मतलब बीपी हाई था, प्रोटीनूरिया था। अब हमको केवल ये देखना है इस क्वेश्चन में, इस प्रेगनेंसी में प्री-एक्लेम्सिया कैसे देखें? एब्सेंस ऑफ डायस्टोलिक नॉच ऑन डॉपलर, एब्सेंस ऑफ डायस्टोलिक नॉच ऑन डॉपलर इज नॉर्मल, विच ऑफ द फॉलोइंग रिजल्ट्स इज नॉट एन इंडिकेटर? क्वेश्चन में क्या लिखा है? नॉट लिखा है। Persistence of diastolic notch is an indicator for preeclampsia. Normally diastolic notch disappear. तो absence of diastolic notch तो अच्छी बात है. It is not an indicator for preeclampsia. So answer to this question is absence of diastolic notch. High resistance index in uterine artery Doppler. This is indicator of preeclampsia. Average mean arterial BP 90, ये भी इंडिकेटर हो गया। फ्री फीटल डीएनए इन मेटरनल सीरम इंडिकेटर। सो एब्सेंस ऑफ डायस्टोलिक नॉच इज ए गुड साइन। हमने ये इमेज देख ली ऑलरेडी पहले। दिस इज द लिंक ऑफ मिस नेक्स्ट टेलीग्राम ग्रुप वेयर आई एम पोस्टिंग important stuff related to clinical vignettes, important information, important discussion videos, important questions related to our exam, which I am posting daily at 9 p.m. All the faculties of MIST are on this Telegram group and they are posting according to their convenience. So join this MIST Next Telegram group to get important updates regarding all the clinical vignettes and single liner questions. Next question, second last question. A 34-year-old lady, her age is 34 years, she presents with progressive dysmenorrhea and dyspareunia. Oh my God. This is the question which we have been talking about. Who will answer this question? Who will answer this question? Progressive dysmenorrhea, dyspareunia. And she is married for last 7 years. But is not able to conceive. 7 साल शादी को हुए, अभी बच्चा नहीं हुआ। बोलती डॉक्टर साहब महीने के टाइम पे दर्द होता है, आपस में बात करने पे दर्द होता है। आपस में बात करना मतलब पेन ड्यूरिंग इंटरकोर्स। हमने क्या किया? हमने उसको पर वजाइनल एग्जामिनेशन किया एंड ऑन पीवी एग्जामिनेशन यू नोट टेंडर नोड्यूलरिटी ऑन यूट्रोसैक्रल लिगामेंट। विच ऑफ द फॉलोइंग इज मोस्ट लाइकली? कौन बताएगा? हु विल आंसर दिस क्वेश्चन? What is the answer? B. Wonderful. Hitesh, Pooja, Anu, Motilal. Wonderful. Navrang, Aditya, Chubam, Dinesh, Rajesh. Very good. Very good. Wonderful. Kishan, Suchitra, Simran, Dhruv, Chavi, Viraj, Neha. सबके नाम याद हो गए, सबकी चॉकलेट। Playboy, Navi, Amitabh, Bhupendra, Praveen, Amit, Gautam, Rupali. Wonderful, wonderful. Swapnil, very nice. Wonderful. So answer to this question is endometriosis, which we have been talking about since beginning of our session. That if the clinical keywords progressive dysmenorrhea and dyspareunia has been mentioned in the question, answer has to be endometriosis. इसका क्या आंसर होएगा? इसका आंसर होगा endometriosis. Why it is not endometrioma? That's a bigger sign. Pelvic tuberculosis, anorexia, weight loss, low grade evening rise of fever, bilateral adnexal mass. Adenomyosis, more stress will be on menorrhagia. Most common symptom of adenomyosis is menorrhagia. No nodular feeling on per-vaginal examination. Adenomyosis, she will not complain of infertility. Adenomyosis occurs in multiparous around 40 years female. Multiparous. She is not willing to conceive. She is not infertile in adenomyosis. And more stress will be on the word menorrhagia. Symmetrically enlarged uterus. PV, symmetrically enlarged uterus. Halban sign. Adenomyosis. So let's quickly revise the images. This is the image of gunshot or powder burn appearance, where you can see these multiple gunshot or powder burn appearance. These are the deposits of endometrium in peritoneal cavity. Fine. This is Allen-Master syndrome, which we have already seen, endometriosis. The last question of the session, a 42-year-old lady presents with atypical uterine bleeding. Type 1 hysterectomy was performed, means total abdominal hysterectomy was performed, and the hysterectomy specimen is shown in given image. What is most likely diagnosis? So this is the hysterectomy image, where we can see this is the uterus and this is the fibroid inside uterus. So this fibroid inside uterus is a submucous fibroid. So this is the case of leiomyoma, that is uterine fibroid. Why it is not endometrial carcinoma? Had it been endometrial carcinoma, you could see some irregular mass in endometrial cavity. Endometrial polyp would have been like a linear growth polyp. Adenomyosis is symmetrically enlarged uterus. Let me show you few other images here. Look here. This is the fibroid, and we have discussed how can we identify. We have discussed FIGO classification of fibroid. This image question was asked in our exam, and the question was identify the pathology in the given X-ray image in a menopausal lady. So this is a calcified fibroid, which is called popcorn calcification or womb stone. This is red degeneration of fibroid. This is fatty degeneration of fibroid. And this is the HSG image of submucous fibroid, which we have already discussed. This is Boni's myoma clamp, which is used to reduce the blood loss during myomectomy. This is Boni's myoma screw, which is used to hold the uterine fibroid during myomectomy. This is ultrasound image. This is subserous fibroid. This is anterior wall of cervix, anterior wall of uterus, fundus, posterior wall of uterus, and posterior wall of cervix. And you can see this laddu here. This is a case of subserous fibroid. Why this is a subserous fibroid? Because this fibroid is protruding out of outermost layer of uterus serosa. This is a case of intramural uterine fibroid. Again, I will outline anterior wall of cervix, continuing as anterior wall of uterus. This is fundus of uterus, posterior wall of uterus, posterior wall of cervix. And this is the laddu here, which is inside myometrium. So which type of fibroid is this? Intramural. This is the image of submucous fibroid. As you can see, this laddu is protruding in endometrial cavity. So this is the case of submucous fibroid. Just before concluding, हिम्मत का सागर लांघो तो लहर लहर जयकारा होगा. हिम्मत का सागर लांघो. हिम्मत का सागर लांघो तो लहर लहर जयकारा होगा. लेकिन अगर दिल टूटे या सपना टूटे तो पूरी दुनिया में जयकारा होगा. दोबारा बोलता हूं, हिम्मत का सागर लांघो, हिम्मत का सागर लांघो, लहर लहर जयकारा होगा. लेकिन अगर दिल टूटे या सपना टूटे, याद रखना, दुखी मत होना. किसी भी कारण से अगर दिल टूटता है या सपना टूटता है, पूरी दुनिया में जयकारा होगा. Believe me. And with all these words, I would like to thank you for attending this session and wishing you all the very best for 30th July FMGE exam from entire Miss team. And finally, final message from my side, may everyone be healthy, happy and successful. And we should all have a healthy face like this. May everyone be healthy, happy and successful. I won't take much of your time. I would request all of you to go through this video, and believe me, this may be game changer for 30th July FMG exam, because we have covered all the clinical vignettes and almost all related single liner question for those topics. Wishing you all the very best once again. Bye bye, take care, and all the chocolates are due with me.